Recording in progress.
Good evening, everyone. We will be starting the session in few minutes. Thank you. Good evening, one and all. On behalf of International Association for Integrated Oncology, I would like to extend my warm welcome to all the speakers, panelists, and participants for the today's session on expert insights on breast cancer. It's my privilege to welcome our esteemed speaker, Dr. Rakesh Roy, consultant medical oncologist. Today, Dr. Roy will be sharing his insights on HER2 positive breast cancer with brain mets. I would like to also thank our sponsor, DBR. Over to you, sir.
Thank you. First of all, is it possible for you to share the slide deck from your end, Shri?
Sure, sir. Sure. Yogendra, can you?
Yes. Should I start?
Sure, sir. Please. Thank you so much.
Yeah. Okay. Thank you, Shri. Thank you, organizers, for giving me this wonderful platform to share my insights on HER2 positive breast cancer in a specific group of population, that is patients with brain metastasis. And a very good evening to all of you, which includes not only the participants but also the faculty. Next slide, please. So we know that HER2 positive breast cancer is an aggressive disease, and if not detected at right time, it is bound to metastasize very fast. And if we do not treat the patients aggressively from the beginning, the patients are going to succumb to the disease. Around 20 to 25% of the breast cancer population would be having a HER2 positive disease. Amongst them, there will be some HR positive breast cancers and there will be some HR negative breast cancers. Next slide, please. So these are the different types of targeted therapies for HER2-positive breast cancer. It all started 2.5 decades back with trastuzumab, which was a monoclonal antibody. Then we came to know that HER2 HER3 dimerization is a very strong nitrogenic signal in the HER2 pathway. So that's what came the introduction of pertuzumab. So pertuzumab in combination with trastuzumab was very effective in blocking the dimerization and stopping the very strong nitrogenic HER2 signaling. Then we came to know that there are drugs called antibody drug conjugates, which is a combination of antibody along with a chemotherapeutic agent. And the idea was to deliver this combination drugs to the site of target, and that's where the molecule used to dissociate it into the chemotherapy, and the active chemotherapeutic drug used to damage the cells from inside. So antibody drug conjugate was a useful introduction, and then came margetuximab. Margetuximab was actually a genetically engineered trastuzumab to overcome trastuzumab resistance. Apart from the monoclonal antibodies and antibody drug conjugates, we also have access to small molecules, which are the tyrosine kinase inhibitors. They actually work from inside the cell and block some important tyrosine kinase pathway mediated HER2 signaling. Apart from this, there are other pathways also which can actually co-function in inducing HER2 signaling, and we have drugs like everolimus, temsirolimus, which block the PIK3 inhibitor pathway. Next slide, please. Now, what is the standard of care currently for first line and second line HER2 positive metastatic breast cancer? So, the Cleopatra study actually cemented the position of triplet therapy in first line metastatic HER2 positive breast cancer. And this,
So we are sorry to interrupt you, sir. Your voice is not clear. Could you be bit loud, please?
yeah, just a second. Can you hear me now? Is it
Much
better?
better. Yes, sir. It's better now, sir. Thank you.
So, what are the existing standard of care in first line and second line treatment of HER2 positive metastatic breast cancer? In the first line, we have the Cleopatra study that cemented the triplet therapy of taxane, trastuzumab, and pertuzumab for all the patients who presented after. The comparator was a combination of taxane and trastuzumab, that is TH, and you can clearly see that very few patients had an exposure to trastuzumab at that point of time. If you look at the difference in overall response rate, it was 80% versus 69% in favor of THP regimen. If you look at the delta for median progression-free survival, a difference of 6.3 months in favor of THP compared to TH. And if you look at the median overall survival delta, a difference of 16.3 months in favor of THP once again compared to TH. So overwhelming median overall survival difference of almost 1.5 years. If you combine three drugs, pertuzumab, trastuzumab, and taxane, and delivered to treatment-naive metastatic breast cancer patients who are HER2 positive. If you look at the treatment-related adverse events, the common ones were diarrhea, alopecia, neutropenia, so on and so forth. But only 2% of the patients had a higher grade 3 or more adverse effects with the THP arm compared to TH. So it was more or less well tolerated. So the first line standard of care in HER2 positive metastatic breast cancer stands pertuzumab, trastuzumab, and taxane. We move on to the next slide, please. Next click. Yes. So in second line, the standard of care is TDN1. It used to be at one point of time. Now it is being gradually replaced by TDXT. But it was the Emilia study that cemented TDN1's position in second line for patients who had previously received trastuzumab. This was compared with lapatinib and capecitabine. Remember, 84% of the patient population in the Emilia study were metastatic and 16% had early disease. So if you look at the overall response rate, a superior overall response rate in favor of TDN1 compared to lapatinib capecitabine, a superior median progression-free survival, as well as a superior median overall survival. But if you look at the comparative deltas between first line and second line, They have drastically come down. It is quite understandable because the moment you push from first to second line, the responses tend to come down. If you look at the common treatment-related adverse events, diarrhea, fatigue, nausea, elevated taste, and thrombocytopenia, the common ones, 16% of higher toxicity was noticed in the control arm or comparator arm compared to TDM1. So TDM1 emerged as a standard of care in second-line patients with HER2-positive MBC who had previous exposure to trastuzumab, and it was more better tolerated compared to patients who were getting lab cap combination. Next slide, please. Now, what happens is the moment you progress from first line to second line, the median progression-free survival data drops. With Cleopatra, what used to be an overwhelming response, that drastically came down the moment you went on to second line with TDM1. Now, remember, the Cleopatra for first line and Emilia for second line, these two trials were conducted globally more or less at the same time. They were initiated simultaneously. So none of the patients in Emilia's study, which compared TDM1 with LabCap, had an exposure to pertuzumab. So that was one of the biggest drawbacks of the study. Can we move on to the next slide? So the evidence suggests that the progression-free survival outcomes for second-line TDM1 are worse in patients who received prior pertuzumab. So as I said earlier, in Emilia's study, none of the patients had an exposure to pertuzumab. Therefore, TDM1 looked very, very superior compared to LabCap. But if the patients, which is now the standard of care, receive pertuzumab in first line, the moment you put them in second line TDM1, they may not get similar amount of response that was actually obtained in the Emilia study. So two very major Italian trials showed that if you give trastuzumab, pertuzumab first line, and then you put these patients on TDM1 once they progress, the response is not that much. Next slide, please. So what could be the reason for reduced outcomes with TDM1? Once the patient has progressed on pertuzumab, it could be due to reduced HER2 expression. Next slide, please. Now, a lot of drugs were actually introduced one after the other. In the last 6-7 years, we have had an introduction to trastuzumab deruxtecan. We have now access to drugs like neratinib and tucatinib, which are small molecules, tyrosine kinase inhibitors. And finally, during the COVID times, came margetuximab, which is actually a genetically engineered trastuzumab to overcome basic trastuzumab resistance. Next slide, please. So when we know that TDM1 may not respond well to patients previously exposed to pertuzumab, they decided to bring forward a new molecule and they wanted to test it. So the Destiny Breast 02 was a randomized phase 3 open-label multi-center study which wanted to see whether TDXT, a second antibody drug conjugate, was superior to treatment as per physician's choice. So the key eligibility criteria were So the key eligibility criteria were centrally confirmed HER2 positive unresectable or metastatic breast cancer, documented radiographic progression after most recent treatment, and previously treated with TDM1. The stratification factors were hormone receptor status, prior treatment with pertuzumab, and history of visceral disease. It was a 2:1 randomization. A majority of the patients got 3-weekly TDXT at a dose of 5.4 milligram per kg body weight compared to the comparator or control arm, where lapatinib was combined with capecitabine and trastuzumab was combined with capecitabine, and it was the discretion of the physician which one is to be given. The primary endpoint was progression-free survival. The key secondary endpoint was overall survival, and there were a host of other secondary endpoints like overall response rate, duration of response, safety, so on and so forth. Next slide, please. So the primary endpoint, as you can see in the Kaplan-Meier curve for PFS, there was a huge difference in PFS between TDXT and TPC, that is treatment as per physician's choice, almost 3 times, almost trebling of progression-free survival in favor of TDXT. If you look at the number of patients who had not progressed at about 24 months, it was 42% with TDXT and only a meager 13.9% with TPC, that is treatment as per physician's choice. Next slide, please. A similar trend was seen in the Kaplan-Meier curve for overall survival. Once again, 39.2 months of median OS with TDXT and only 26.5 months of median OS with TPC, significant hazard ratio. 25% of the patients received TDXT subsequently in the post-trial setting. Next slide, please. If you look at the overall response rate, this waterfall curve actually shows that a substantial number of patients under the TDXT arm either had a complete response or partial response compared to patients who got TPC. Next slide, please. So having seen the encouraging data from the Destiny Breast 02 study and knowing that TDXT has certain special attributes compared to TDM1, for instance, a higher bystander effect and a higher payload, the researchers decided to pull off the Breast 03 Destiny study, which was once again an open-label multi-center phase 3 study. And this time they wanted to have a head-on comparison between TDXT and TDM1 in the similar setting to see which is more effective. So once again, unresectable or metastatic HER2 positive breast cancer patients could have been clinically stable, treated brain metastasis greater or equal to 2 weeks between end of whole brain radiotherapy and study enrollment, prior treatment with pertuzumab, history of visceral disease, hormone receptor status. These three were the stratification factors. So these patients were directly compared between TDXT and TDM1. The doses are mentioned, and the primary endpoint was progression-free survival, and the key secondary endpoint was overall survival. Next slide. You can clearly see from the Kaplan-Meier curve for progression-free survival, TDXT was a clear winner. 28.8 was the median progression-free survival with TDXT versus 6.8 with TDM1. Almost 4 times the PFS benefit that you get with TDXT. At about 24 months, if you see 53.7% of the patients had not progressed with TDXT compared to 26.4% with TDM1. Next slide, please. I'm sorry. Next slide, please. The slides are not moving at my end. Yeah, now it's okay. If you look at the confirmed overall response rate and other efficacy endpoints, you can clearly see TDXT is a clear winner compared to TDM1, not only in terms of partial responses, but also in terms of complete responses. Next slide, please. So TDXT is probably now the standard of care in second line because it is superior to TDM1 and probably the way to go forward if the patients have received pertuzumab in first line HER2 positive metastatic breast cancer. Now, what about third line? Do we have any drug? There is a new kid in the block called tucatinib, also called Tukisa. This is a small molecule, a tyrosine kinase inhibitor, very potent, and is probably going to be the third line standard of care for patients with HER2 positive metastatic breast cancer. Next slide, please. So it is basically a reversible HER2 small molecule inhibitor. It's a tyrosine kinase inhibitor, acts from inside the cell and blocks several HER2 mediated pathways and the final common pathway, which is responsible for the mitogenic HER2 signaling. Next slide, please. So the indication is tucatinib is indicated in combination with trastuzumab and capecitabine for the treatment of adult patients with HER2 positive, locally advanced or metastatic breast cancer who have received at least 2 prior anti-HER2 treatment regimens. Next slide, please. So the HER2 CLIMB study is the registration study that cemented the position of tucatinib in third line HER2 positive disease. It was a randomized, double-blind, multi-center, international, placebo-controlled phase 3 study. The key eligibility criteria were HER2-positive MBC, prior treatment exposure with trastuzumab, pertuzumab, and TDM1, ECOG performance status of 0 or 1, and they were generous to take different kinds of brain metastasis patients. Mandatory mandatory brain MRI at baseline. So they had included patients who were previously treated at stable brain metastasis, untreated brain metastasis not needing immediate local therapy, previously treated progressive brain metastasis not needing immediate local therapy, and patients without any evidence of brain metastasis. Stratification was done on the basis of presence or absence of brain metastasis, performance status, and region-wise distribution of the patients. So it was a 2:1 randomization. A tucatinib triplet was compared with a placebo combination of trastuzumab and capecitabine, and both were given every 3 weeks, and they were assessed for treatment response. Next slide, please. So if you look at the baseline characteristics of the patients, they were evenly matched between the two groups in terms of sex, in terms of age, race, geographical distribution, hormone receptor status, performance status, stage of the disease at presentation, presence or absence of brain metastasis, number of mets versus which are the viscera that were involved, number of lines of therapy, and the exposure to previous drugs. Now, most importantly, the major significant enrollment criteria for the HER2 study was that patients must have had an exposure to trastuzumab, pertuzumab, TDM1, 100% exposure to all these three drugs. This was the basic and the most important requirement for HER2 study. Moving on to the next slide. So if you look at the Kaplan-Meier curve for progression-free survival, you can clearly see the tucatinib combination was superior to placebo combination in terms of PFS, 7.8 versus 5.6 months. If you look at the number of patients who had not progressed at 12 months, it was 33% with tucatinib and 12% with placebo combination. Next slide, please. If you do the subgroup analysis for PFS, you will see every single parameter favors the tucatinib combination rather than the placebo combination. So whether it is age, race, hormone receptor status, baseline brain metastasis, yes or no, performance status, and geographical distribution. Next slide. A similar kind of trend was also seen with the Kaplan-Meier curve for overall survival. A better overall survival with tucatinib combination, 21.9 months versus 17.4 months with the control arm. Next slide, please. And once again, if you do a subgroup analysis for overall survival, every single parameter falls to the left of the median line favoring tucatinib-based combination. Next slide, please. So what about the patients who had brain metastasis? Because this is the most important aspect of my talk. PFS in patients with brain metastasis. You can clearly see the patients who had brain metastasis, and I already mentioned what kind of brain metastatic patients were actually recruited for this study. There's a significant PFS improvement for patients with brain mets if you give tucatinib in combination with trastuzumab capecitabine versus the placebo combination. So 7.6 months versus 5.4 months, a hazard ratio of 0.48 indicating there's a 52% reduction in the risk of progression intracranially if you give tucatinib-based combinations. Next slide. Once again, the subgroup analysis, even for patients with brain metastasis, favored tucatinib combination. In fact, every single parameter falls to the left of the median line. Next slide, please. So what Tupisa does, tucatinib significantly extends overall survival in patients with brain metastasis, a difference of 6 months, and a 42% reduction in the risk of death. Next slide. There is a 43% reduction in the risk of progression or death if you consider progression-free survival. Even that was superior when you give tucatinib rather than placebo in combination with trastuzumab capecitabine. So tucatinib shows a better intracranial OS as well as a better intracranial PFS compared to placebo combinations. Next slide. Now, there were a significant number of patients who had brain metastasis, and there were a significant number of patients who had visceral metastasis. So, HER2CLIMB is the first double-blind randomized trial to include patients with active and progressing brain metastasis. Next slide. Now, what about the safety profile? Well, it's quite understandable that if you give a triplet regimen, there will be higher incidence of adverse effects. But if you look at the number of patients who experience grade 4 toxicity, it was 0.5, and grade 3 toxicity was 12.4 with the triplet compared to the doublet. Next slide. The adverse events of interest were with the GI symptoms, especially diarrhea, and hand and foot syndrome, which is also called PP syndrome or palmoplantar erythrodysesthesia. These were the ones of interest. And also the patients experienced nausea and vomiting to an extent higher with tucatinib-based combination, but the numbers with this combination as far as grade 3 or grade 4 toxicity is concerned were not very different from the ones which was recorded with placebo combinations. Next slide, please. So what is the dosage pattern for tucatinib? It is 300 milligram twice daily, given in combination with capecitabine and trastuzumab. Tucatinib is given non-stop without a break. Capecitabine is given for 14 days, and trastuzumab is usually given every 21 days. Next slide. So how do you de-escalate if the patient is experiencing tolerance issues? You actually de-escalate it by 50 milligrams, so 300 milligrams twice daily to 250, then 200, and finally 150 milligrams twice daily. Tucatinib should be permanently discontinued in patients unable to tolerate 150 milligrams orally twice daily. Next slide. So these are the four drugs, the so-called small molecules, tyrosine kinase inhibitors, which are being compared. Remember, tucatinib and lapatinib are reversible HER2 blockers, whereas niratinib and pyrotinib are irreversible. That is why they experience so much of toxicity with these molecules. Next slide, please. As I said earlier, diarrhea and hand and foot syndrome are the two most important adverse effects of interest, but the incidence of grade 3, grade 4 toxicity was much less. And cardiovascular wise, there wasn't substantial reduction in ejection fraction if you combine drugs like tucatinib with capecitabine and lapatinib. Next slide. What about the patients of special population? You do not need to do dose adjustment for elderly patients above 65 years. You do not need to make any dose adjustments for patients who have mild, moderate, or severe renal impairment, but patients who have a childhood severe hepatic impairment, you need to reduce the dose to 200 milligram orally twice daily. That's what is recommended. Next slide. There is some amount of warning and precaution for this molecule. You have to be very careful regarding severe hepatotoxicity, especially for patients who have extensive liver disease. And once it comes to diarrhea, you have to manage diarrhea very, very quickly and proactively because it can lead to dehydration, acute kidney injury, so on and so forth. Next slide, please. Now, there is some amount of drug-drug interaction between tucatinib and the other drugs. So the drugs which are strong CYP3A or moderate CYP2C8 inducers usually avoid co-administration because that can actually lead to either increase in toxicity or reduce efficacy of this molecule. Next slide. So what are the current treatment options for HER2-positive metastatic breast cancer? In first line, you have a triplet combination of dual anti-HER2 therapy, pertuzumab, trastuzumab in combination with a taxane. You can give any form of taxane. It could be docetaxel, it could be paclitaxel, or it could be albumin-bound paclitaxel. Once the patients have progressed to second line, you can give TDXT, or you can actually push up tucatinib in the order if you think that the patients are actually comfortable and appropriate for this regimen. There is a category 1 recommendation for this. And the classical third line option would be ticatinib in combination with trastuzumab and capecitabine for patients who had previous exposure to all those three agents, which I mentioned in the HER2 client study. Next slide. You can clearly see the NCCN, the latest version recommends for patients who have recurrent unresectable HER2 positive breast cancer. The third line standard of care would be tucatinib in combination with trastuzumab capecitabine. There is a possibility of giving TDN1 or other drugs if the patient has not received those drugs before. Next slide. Yes, I think with that I would end my talk and I'm ready to take questions if there are any.
Thank you so much for such a insightful session, sir. We also thank BDR for sponsoring this session.
Thank you.
We are delighted to have with us Dr. Shavankar Basak, Diagnostic Lead, AstraZeneca. We thank AstraZeneca for sponsoring this session. I now invite him to introduce our next session. Over to you, sir.
Thank you, Sri Lakshmi. Hope I am audible.
Yes, sir, loud and
Okay.
clear.
Thank you so much. Good evening, everyone, to all the participants as well as the faculty. And I also take this opportunity to thank IAIO for crafting this beautiful agenda. So in this session, we have a very power-packed speakers. We have Dr. P.N. Mahapatra, who will be talking about the treatment landscape of HER2 spectrum in breast cancer. And then we have a very important talk by Dr. Devmalle Banerjee. And Dr. Devmalle will be talking about the newer aspects of HER2. That's the HER2 low and HER2 low, ultra low, its scoring and interpretation in breast tumors. And then we have a power-packed panel discussion with many experts in this field to understand the HER2 scoring in breast cancer, its new classification, and the different aspects of testing. But before I hand over to Sri Lakshmi to invite Dr. Mohapatra, I just want to take a couple of minutes to highlight the importance of guideline-based testing when the HER2 testing going into a more complex arena. Can we have the next slide, please? So as the entry HER2 therapy has evolved simultaneously, the HER2 testing also evolved along with that. Two very important milestones. Way back in 1998, the first FDA-approved companion diagnostics test came into the picture. And the second, in 2007, when ASCO-CAP first given the guideline of HER2 testing. Simultaneously, multiple times the guideline also evolved or updated. The latest update came in 2023. Can we have the next slide, please? Now in 2023 updates, ASCO-CAP mentioned very clearly, and I have highlighted that in green, and they have mentioned, quote unquote, while it is premature to change reporting terminology for lower level of HER2 IHC classification, that is HER2 low, pathology labs should include footnote in their HER2 testing report. That means guidelines is not making HER2 low or HER2 ultra low terminology in the report. That implies, pathologist needs to report in based on the guideline, and then the treating physician needs to corroborate with the definition of HER2 low and ultra low to identify the patient who can get benefit with the appropriate treatment therapy. I am not going into the operative part. Can we go to the next slide, please? In this year, in March, CAP also updated the reporting template. They have done some of the structural changes, which I have mentioned in the right side in the top corner. And then in June, subsequently, they have also made some smaller changes. The most important thing came in the month of March update, reporting the IHC staining pattern in each score, IHH groups, and heterogeneity details. So are we there? What is the ground truth? Let's look into the next slide. Next slide, please. So here I am showing a real-time report of one of the hospitals. And you can see here, HER2 is mentioned as negative and score 0. Can you please click once again? Okay, that means whatever is mentioned in the reporting format in CAP, that's not been followed. So can a medical oncologist take an informed decision with just mentioning the score 0? I think that's one of the problem, adoption of the right treatment, right guideline-based reporting in case of HER2. Can we go to the next slide, please? Go to the next slide, please. So College of American Pathologists also mentioned how to report, how to optimize the report. Please go to the next slide. And they have given 4 different categories. First category is the patient and physician identifier and date of service. Second category, specimen details, specimen identification details and specimen site and type details. Third category is very important, which is the HER2 by immunohistochemistry status. And you can see here, now CAP has introduced a new scoring category there as 0+. And 0+, they have correlated with HER2 ultra low. And they also recommended to mention the score, the staining pattern, whether it's weak, moderate, intense membrane staining, complete, incomplete. Most important, the percentage of cells with described pattern, and the score, which is very important for the clinicians to corroborate with the definition of HER2 ultra low, the cluster heterogeneity, and the comments. They also given a very crisp recommended comments and methodology part, which includes the cold ischemic time, fixation time, which fixity, what type of antibody. So very detailed structured reporting format CAP has recommended. I am sure in our session, the pathologist will also highlight how to report, how to optimize the report, along with the HER2 scoring, the differentiation between HER2 ultra low and low. And with this, I'll stop here and I'll ask Sri Lakshmi to invite Dr. P.N. Mahapatra so that we can understand why to test HER2 and how we should look through a different lens now for HER2 low, ultra low, and the different other nuances of the practice. Thank you so much. Over to you, Lakshmi.
Thank you so much, sir. Moving forward, it's my pleasure to welcome Dr. P.N. Mohapatra, Medical Oncologist, Director of Medical Oncology, Apollo Cancer Center, Kolkata. Dr. Mohapatra will be presenting on the topic, Treatment Landscape of HER2 Spectrum in Breast Cancer. Over to you, sir.
Thank you. Thank you. Next slide, please. You have already introduced this subject actually. If you see actually the breast cancer is actually either is a hormone positive, HER2 positive or triple negative. Actually, if somebody have the HER2 positive overlaps with the TNBC part actually, and they overlaps with the hormone positive part. Actually, if somebody is hormone positive, HER2 positive, we think the disease is aggressive. If it is hormone negative, HER2 positive, it is more aggressive. The most aggressive is the triple negative actually. They occur in young patient, and hormone positive actually some patient actually the old females come with lump for 1 year and they're very slow growing. We do a PET scan, we don't see any patient has any metastatic disease. Next slide, please. So it's actually long time back. We went to ASMO, and the Cleopatra trial came, and which showed in metastatic breast cancer, the PFS is 16.8 month, and subsequently the Emilia trial. That time only antibody drug conjugate was TDM1, and it shows a PFS of 9.6 month actually. But when the Emilia trial was done, actually no patient were pertuzumab pretreated. If you see after pertuzumab pretreatment, actually TDM1 doesn't do well. The current actually, if you see the trials, actually the trial they will show a PFS of 6 to 7 months. So that was the standard. Next slide. So then came actually the Destiny trial. The Destiny, they started with a phase 2 trial, phase 1, dose finding trial, phase 2 trial. Then this is a phase 3 trial. Actually, they wanted to put it in the first line, actually, after first line in the metastatic setting. And the and actually it showed a PFS around 25 months, 3 times more than the TDM1. Next slide. This is the PFS actually. If you see, it is a 3 times more than the TDM1 actually. It is 25 month actually. If somebody you get a 16.8 month in the first line with Patu, docetaxel and trastuzumab, and you use TDXD actually, and you get a 25-month PFS actually. That is for the HER2 positive. This is a big actually progression-free survival. Next slide. So after the Destiny Breast 03, the TDXT became the standard second line treatment after Cleopatra actually. And actually third line, it's not TDM1, it's maybe tucatinib, anything actually. There may not be the standard line after TDXT, may not be many treatments are not much effective actually. Next slide. So if you see the HER2 scenario actually, if somebody have a our breast cancer patient, hormone positive will be 70% and hormone negative will be 30%. If you see the total HER2 3 plus scenario actually, 15% will be both HER2 when a hormone positive and HER2 positive, and 5% will be hormone negative, HER2 positive. So what we used to do actually, if somebody is HER2 positive, we used to give trastuzumab, then pertuzumab with chemotherapy came, then TDM1 came, actually, and after that now TDXT came actually. But before that actually we have to give hormone therapy, trastuzumab. If somebody is HER2 positive, hormone therapy, and once hormone therapy is not working, then only chemotherapy. And triple negative from the beginning, chemotherapy, or somebody which who are eligible, immunotherapy and chemotherapy. Next slide. And when we started our practice, actually the HER2 reporting was like this actually: ER positive, HER2 negative. They were not, nobody was reporting actually 1 plus, 2 plus, 3 plus. Slowly now everything is changing, and because of the drug, the reporting is getting very finer actually. So, what is the concept of HER2 low and HER2 ultra low? Next slide. So, if you see the IC staining, actually, what was previously done, whether the slight incomplete staining, actually, less than 10% of the patient they were reporting is actually 0%. Incomplete staining more than 10%, it was 1 plus. Weak to moderate staining was 2 plus actually, and there we have to do fish test. 50% may be fish positive, 50% may be fish negative. And if there is intense staining, it's more than 10% cells, that is up to 3 plus. But here the pathologist impression is very important. One of the means any pathologist who is giving a heart to 1 plus 2 plus 3 plus, they must be very important actually. So what when slowly we have actually because of destiny 04 because of trastuzumab deruxtecan, the pathologist also started reporting 0, 1, 2, and when 2 we do fish test and 3 actually. But ultra low, I think still when not many pathologists are reporting actually. Next slide. So what is Destiny Breast 04? Actually, what made us to test HER2, and actually if you see the HER2 scenario, only 20% of the patient were able to take HER2 directed therapy. So rest actually 1 plus 2 plus were never able to take. So Destiny 04 because the trastuzumab deruxtecan is a very strong antibody drug conjugate which works because of the effect in the cell and the surrounding cells actually. Then they thought ki it is maybe working in 1 plus 2 plus patient. Preclinical data showed it is working, so they designed the trial. This is Destiny Breast 04. Next slide. So this is actually HR positive patient or triple negative patient actually. If somebody is 2 lines of chemotherapy, if somebody is hormone positive, they must have hormone refractory. They must have taken CDK4/6 inhibitors, but CDK4/6 was not the must for this trial, but they must be hormone refractory. Hormone is not working. So they divided the patient, either it is a 2 plus FIS negative or 1 plus, and mm, this patient actually, then the drug was TDXT and physician choice chemotherapy. Physicians here they used as usual the capecitabine, eribulin and taxanes actually. All the trials actually Destiny 4, 6, the primary endpoint was PFS and secondary endpoint was OS and response rate. Next slide. Actually, they actually stratified this slide into the trial into CDK4 taken, not taken, high volume disease, which is more than 3 or more disease, or low volume disease, rapid progressor, non-rapid progressor. If somebody is progressing more than 6 months or somebody is progressing less than 6 months, brain metastasis, yes or no, prior adrenaline taken or not, they stratified this patient, but overall, if you see, the endpoint was two actually. One is in the hormone positive patient and the overall patient, and in the triple negative patient, they actually this is a analysis which was not one in the trial. This is and if you see the PFS actually, this is around 49% to 50% improvement in the PFS. And in this type of population where chemotherapy is given, already hormone therapy is given, the PFS is around 10.1 and the and 9.9 actually in the overall population. Next slide. So OS actually in this trial actually is in this heavily pretreated population, which is HER2 1 plus 2 plus is not HER2 positive. The OS actually reaching around 2 years actually. It is actually 6 months better than the physician choice of chemotherapy. You are getting within this setting, if you get a 6 month overall survival advantage, this is very big difference. Next slide. So the analysis which is in triple negative, this is here they have not chosen HER2 ultra low, this is HER2 0 that time. Actually that patient actually the analysis was exploratory, but here also it is working, maybe working because of the HER2 ultra low population, and it is actually 17.1 month was the survival, and the PFS actually is around 6.3 month, and this type of population physician choice of chemotherapy was very less, and within 3 years actually every patient progresses. Next slide. So if you see the how many patient would be eligible for the treatment, if you see the HR positive patient, if you include the patient which are had to low, then you have to increasing patient around 60% actually. And in the if you have somebody is HR negative, hard to low, 40% of the patients still are eligible for treatment. So you are expanding the treatment of the patient who are actually eligible for trastuzumab deruxtecan. Next slide. So Destiny 04 actually told us ki you have to see discuss with your pathologist, you have to see the reporting of the pathologist, whether the HER2 is 1 plus, 2 plus, you must not miss anything so that our patient will get the best treatment possible. Next slide. So when actually, if you see previously, the ASCO ESMO guidelines actually were telling it is either HER2 positive or HER2 negative. Then slowly they evolved actually. Then now actually, if you see, there it is totally HER2 negative, that is HER2 null actually, ultra low, which is HER2 negative or any staining. Actually, any staining of the cells is called ultra low. If it is low, and then actually 1 plus, 2 plus, and 2 plus you have a FIS positive or FIS negative. Next slide. So this update actually, we am now 1 plus 2 plus till Destiny 04. Now you have a ultra low 1 plus 2 plus after the Destiny 06 trial. Next slide. Now we have to go to the Destiny Breast 06 trial. This is the recent actually. Actually, maximum patient of ours are hormone positive. Actually, the guidelines tell if it's somebody is a hormone positive disease, you have to give hormones, and no guidelines tell ki chemotherapy increases the survival in hormone positive disease. So after hormone therapy, basically we'll end up in chemotherapy, and the patient outcome is very poor with chemotherapy. So with the Destiny Breast 06, actually they included patient which are HR positive, progressing with hormone therapy. Next slide. So here actually the concept of ultra low, because in the previous trial they saw some patient actually in triple negative, it's working actually. So it is ultra low came into picture actually. And so the results actually are IC2 plus, 1 plus, ultra low, and null type. Null type, no staining. Ultra low is less than 10%, some staining actually. And so the total HER2 scenario has been changed now to totally no staining to very minimal staining to 2 plus staining. So any staining in the HER2 and the trastuzumab deruxtecan will be effective. Next slide. Next slide. So this is the Destiny Breast 06. Actually, if you see the Destiny 04 and if you 06, actually, you have more than 20-25% extra patient you can treat with trastuzumab deruxtecan. Next slide. Next slide. So why trastuzumab deruxtecan is so effective? The mechanism of action. Next slide. This is actually antibody drug conjugate. It's if you give the chemotherapy drug, this type of drugs in the IV, actually very toxic. So you have to combine with a monoclonal antibody. Here it's a trastuzumab actually, and the payload is topoisomerase 1 inhibitor. This is deruxtecan. Actually, they have a clearable linker. Next slide. Actually, what happens if somebody any expression of the HER2, they will enter the cells, and there the cleavable linker is dissolved actually, and the deruxtecan actually kills the cell and they kill the surrounding cell. So it is called the bystander effect. The deruxtecan actually the main why it is effective in 1+, 2+ ultra low because of the bystander effect. Next slide. So the Destiny Breast 06 was designed actually. This is HER2 positive disease actually, an hormone positive disease, and they either it is a 1+, 2+, or ultra low actually. Either it's a 2 line of hormone therapy, or if 1 line of hormone therapy, if there is hormone resistant actually. In adjuvant setting, it is less than 2 years, or in the metastatic setting, it is less than 6 months. It is primary hormone resistant patients actually, and you this TDXT, and here actually because they are coming in the previous line actually, there is no capecitabine, no eribulin actually. They come no eribulin actually. They combined with capecitabine, nab-paclitaxel or paclitaxel, which is the standard chemotherapy in this type of patient. And the outcome was PFS and PFS OS and response rate and toxicity. Next slide. So let's see the result. Next slide. Next slide. So actually, if you see the in this hormone refractory patient not given chemotherapy, actually it is the PFS is actually 13 months actually, and the chemotherapy only 5 months actually, 13.2 months. So this is very effective in chemotherapy in HER2 low and patient. They also analyzed in the HER2 ultra low. In this patient actually 153 patient were ultra low and 700 something were HER2 low patient. Next slide. Next slide. So in HER2 low and the intention to treat population, that is the total population actually, you can see the both the PFS is increasing actually. And in OS actually, and this is 30% mature, and you can see you can slowly the curves are little bit separate after some time, and it's not a mature OS actually. Once the maturity comes, the OS result will be better actually. Next slide. Next slide. Next slide. Response rate actually, if you see the response rate actually, the both in HER2 ultra low and HER2 low response is around HER2 ultra low it's reached around 60%, and HER2 low actually it is around 57%. It is much better than chemotherapy because it's antibody drug conjugate. You expect a good response actually. So Destiny Breast 06 actually, if you post hormone therapy, if you use trastuzumab deruxtecan, you get a better PFS and better response rate. Toxicity actually is still from the beginning. What is the toxicity? Is the main concern toxicity is ILD, and what when it is around 10%, 11%. Fortunately, with learning the more Destiny trials actually, the earlier the ILD has been recognized, so deaths are less common. Next slide. So these are the ESMO guidelines actually, and now if you see all the guidelines actually, HER2 low, HER2 positive, HER2 ultra low, you will see trastuzumab deruxtecan in CNS metastasis everywhere. You will see trastuzumab deruxtecan. Next slide. So this is an NCCN actually. You see ESMO, NCCN, every guidelines actually. First line actually after in metastatic setting after the pertuzumab, trastuzumab chemotherapy. This everywhere actually hormone positive disease everywhere HER2 low, ultra low, trastuzumab deruxtecan is there. Next slide. Actually, and the key takeaways are actually Destiny Breast 03. Actually, second line, I don't know when it will replace as the first line also. But Destiny 04 actually, either HR positive or HR negative. If somebody have a 1+2+, you can use deruxtecan. And in hormone positive disease, if it is the HER2 is 1+2+, ultra low, better to use deruxtecan before any chemotherapy. So, maximum guidelines and guidelines are there to change actually, and deruxtecan has taken hard to 80 to 85% of the patient now can be treated with trastuzumab deruxtecan. Thank you. Thank you. Thank you.
Thank you, Dr. Mohan Patra, for such an insightful session. Next, it's my pleasure to welcome Dr. Devamalya Banerjee, oncopathologist, senior consultant, Narayana Health, Kolkata, who will be delivering the topic HER2 scoring and interpretation in the HER2 low and HER2 ultra low breast tumors. Over to you, sir.
Good evening, everyone. Am I audible?
Yes, sir. You're audible.
Uh, so next slide first. Can you please change the next slide? The first slide, basically. Yeah. So first thing, what is the HER2 new? It is basically human epidermal growth factor receptor. And there are the 4 members in the entire family, HER family. Number 1 is the HER1, HER2, HER3, and HER4. And our point of interest is mostly the HER2 because it is among these 4 members in the family, it is the most potent. So the gene which translate the HER2 protein, basically known as the ERBB2 gene, and you all know that it is located in the chromosome number 17, the long arm. And another important thing is that for the HER2, there is no specific receptor. So what happens when the ligand bind to HER1, HER3, or HER4 receptor, this ligand receptor complex.
Sorry to interrupt, sir. Could you please switch on your camera?
Oh, it's off. Okay.
Thank you, sir.
Yeah. So just one minute. Yeah. So when the HER1, when the ligand bind to the receptor, the HER1, HER3, or HER4, this ligand receptor complex, it bind to the HER2 receptor and they form a heterodimer. So that heterodimer that initiate the signal transductions downstream to the nucleus. And the basic role of the HER2 molecule is the growth, survival, and the differentiation of the cells. So it is not like that it is only the cancer cells, they have the ERBB2 gene and the HER2 molecule on its surface. It is present in the normal cells also. So that's why the ERBB2 is basically a proto-oncogenes. So when its functions overactivated, then there is the error in the tumorigenesis. So it is present in the normal epithelial cells, duct, and the acinar lining epithelial cells of the breast parenchyma. Next slide, please. So what types of the HER2 alteration we expect? So number 1, it is the gene mutation that include the single nucleotide variants or the exon 20 insertions. So if this type of the mutations present in the ERBB2 gene, then what happens? The antibody drug conjugates and the receptors when binds, they enhance its internalizations, and that's why it increases the uptake of the antibody drug conjugate in the cells. So one of our target is the ERBB2 gene mutations by either SNB or exon 20. Second most common, but there is a maximum common things is the HER2 alteration is the HER2 amplification. Amplification means there is a high number of the HER2 gene in the chromosome. Number 3 is the HER2 overexpressions. Overexpression means when there is a HER2 molecules that are increased on the cell surface. So these 3 kinds of the alteration we expect in the ERBB2 genes. Next slide. So there are the different methods of techniques to identify the different kind of the alterations. So the techniques for the identifying the overexpressions, techniques for the identifying the amplifications, and techniques for identifying the mutations are not the same, definitely. For the HER2 mutation analysis, so if you want to identify the SNV or exon 20 insertions, the preferred technique is either NGS or PCR, and the formalin fixed paraffin emitted block or the circulating tumor DNA, we can go for the test. Second is the HER2 amplification. For the amplification, either the in situ hybridization technique or less commonly NGS, which is not approved by US FDA till now. The HER2 amplifications, the ISH techniques, either FISH or by the chromosonic in situ hybridization techniques, is approved and we can go for it. So in that case, the formalin fixed paraffin emitted blocks are preferred. Number 3 is the HER2 overexpression. That means the number of the HER2 molecules present on the cell surface. That for identification of HER2 overexpression, the IHC is the preferred method. And we know very well the paraffin blocks are the basic materials for the IHC test. Next slide. So this is a very interesting slide, basically. So, and I have already told that the HER2 is not present only the tumor cells. It is present in the normal cells also. So normal breast epithelial cells, one copy of the HER2 gene can translate the 20,000 HER2 receptor molecules on the cell surface. That means when there's no HER2 amplifications or the mutations, anything is there, the normal HER2 molecules present on the surface of the breast epithelial cell is 20,000. So when we give the scoring 3+, HER2 3+, that means there are 23 lakhs molecule of HER2 receptor present on the cell surface. Similarly, when we give the scoring 2+, it is equivalent to almost 5 lakhs molecule of the HER2 receptor on the cell surface. When you give the HER2 score 1+, that means the 1 lakh molecule of the HER2 receptor on cell surface. And HER2 0 means when you're getting the no staining in the IHC, that means at least 20,000 HER2 molecules are present. So why I'm showing these slides, important is that when it is a 3+ or 2+ and FISH positive, that means there is a HER2 driven pathway are involved in the tumorigenesis. And when it is the 0 or 1+ or 0+, I will describe in the next slides, that means maybe there is a not HER2 driven pathway of a tumorigenesis, but we can use the HER2 molecule as a gateway to deliver the cytotoxic drug within the tumor cells. And that's why the scoring system and everything has changed subsequently. Next slide, please. So why we do the HER2 test? Our basic intention for the HER2 test is that we want to identify more and more HER2 positive cells. HER2 positive cells means where the HER2 gene amplifications or the mRNA that present on the in the cytoplasm. So one of the method of identification of the HER2 positive is the IHC, definitely. And since 2007 to today, 2025, there are lots of changes in the HER2 scoring has happened. So just in these slides, I just want to show you that what are the changes. Before 2007, the IHC 3+ means it is a strong, complete membranous staining in more than 10% tumor cells. So 2007, first ASCO-CAP guidelines was done, and they show that when you are calling the something is more than 10%, there is a very high false positive rate. So that's why they just changes the criteria. And 2007 first ASCO-CAP meeting, they mentioned that IHC 3+ means when there is the strong, complete membranous staining in more than 30% infiltrating breast carcinoma cells. 2013, in the ASCO-CAP guidelines meeting, they've seen that when you make the criteria for the more than 30%, then the false negative rate is high. We are missing the lots of the actual HER2 positive cell patients from the targeted therapies. So then they modify the guidelines and they say that when there is a more than 10% infiltrating tumor cells show the strong, complete membranous staining, it is called the HER2 positive 3+. And 2007-13, they first introduced the concept of in situ hybridization by fish method mainly. 2018, the ASCO-CAP guideline, they clarify what is the in situ hybridization equivocal cases. Okay. And followed by in 2021, 2023, the ASCO-CAP updated guidelines from the prior HER2 testing and what is the difference between the IHC 0 versus 1 plus coding. And 2023, the ESMO publishes the expert consensus on the HER2 low. So this is the entire changes since 2007 to 2023 and 2025. The reporting pattern of HER2 has changed lots of time just to identify more and more true HER2 positive cell patients who can be benefited from the targeted therapy and nowadays from the antibody drug conjugate therapies. Next slide, please. So what is the different method for the HER2 testing? So number one, I have already discussed, when we are interested to identify that HER2 overexpression on the cell surface, the IHC is the preferred method, the only method basically. So it uses the antibodies to detect the HER2 protein expressions. So different antibody clones are available. Some are US FDA approved, some are not. So mostly in our hospitals and other hospitals also, we mostly use the Ventana platforms and the Roche antibody, which is US FDA approved, to identify the high IHC positive or negative, R2 IHC positive or negative cells. Second is the fluorescent in situ hybridization technique, where we uses the fluorescent DNA probe to detect the HER2 gene amplifications. Here we uses the probe which identify the HER2 gene and the probes which identify the centromere. We just give the different fluorochromes attached to these, either greens or reds, and depending on the count, and we count just simply the 50 tumor nuclei or the 100 tumor nuclei in the complicated cases, and just give the ratio, and we can identify that which cells show the HER2 amplifications. Third is the chromogenic in situ hybridization technique, where we uses the digoxygenin labeled DNA probes with chromogenic detections. Here, the fluorescent is not used, and the chemical materials which shows that the positive or negative HER2 signals to detect the HER2 gene amplification. Similarly, there is the cis, that is when you use the dinitrophenol. Cis means the silver in situ hybridization technique, where the dinitrophenol labeled DNA probes are used with chromogenic detections to detect the HER2 gene amplification. And last is the D-dish, where we use the DMP labeled DNA probe as well as the centromeric probe with chromogenic detection. So these are the different techniques for the identifying the HER2 overexpressions as well as the HER2 amplification. Next slide, please. So what is the advantage of the FISH? The most important advantage is that it's a very specific test. And in FISH, we can identify the low level of amplifications as well as the co-amplification also. But what is the disadvantage? So number one, that it is a very much complex techniques. It requires the specimen preparations. It's more complex. Trained technicians are required. Fluorescent microscopes are required. But these are the financial issues. Apart from that, as we have run the FISH lab in our hospital for the last 4 years mostly, have seen one of the most problem of the FISH is that the heterogeneity of the tumor cells. The HER2 is not very much homogeneous, and there are lots of heterogeneous areas is there. So before going for the FISH, we should evaluate the HE slides and the IHC slide very carefully. So and the area which shows the typical 2+ positive area, that area we should apply the probes. So otherwise, if we can apply the other area where there is a 1+ or it is the negative or 0+, then we can get the false negative result. So the heterogeneity is a very big challenge. And another one important challenge is that in FISH, the histological features, it is not, we cannot visualize. That is easily, you can visualize in the DD's techniques. So the in situ components, which can show the HER2 positive, can be falsely reported as a HER2 positive case. But we have to measure the HER2 in the invasive component only. So that's why for every FISH slides, the careful evaluations of the HER2 HE slides is very important. And in the current softwares, there is the provisions, so simultaneously we can assess the HE slides, full scan HE slides, and the FISH images simultaneously so that we can easily identify which are the invasive component and we cannot give the wrong report. This is the one of the disadvantages of the fish tech. So next, please. So what are the 2018 ASFO-CAP HER2 testing algorithm? So this is the very interesting slides where I can show the what changes are done in 2023 ESMO clinical practice recommendation. So if in IHC I am getting the no staining, then it is a HER2 0. And according to the conclusions by the ASFO-CAP guideline, it's a HER2 negative. And 2023 ESMO clinical practice recommendation is that it is HER2 null if we get the no staining. If we get the incomplete faint staining in less than 10% tumor cells, every adjective here is important for my pathology colleagues. That's incomplete and the faint staining in less than 10% tumor cells, invasive tumor cells, then according to the 2018 ASFO-CAP guideline, it is HER2 0. According to the conclusion by ASFO-CAP guideline, it is HER2 negative. And according to the conclusion by 2023 ESMO clinical practice, it is HER2 ultra low. So ultra low means something more than 0, more than null, but is less than 1 plus. Similarly, if we get the incomplete faint staining in more than 10% tumor cells, it is HER2 1 plus. It is also HER2 negative, but according to the 2023 ESMO clinical practice recommendation, it is a HER2 low. And similarly, the patient which shows the HER2 2 plus staining, 2 plus means when it is a weak to moderate but complete staining. So the difference between the 1 plus and 2 plus is that in 2 plus, the complete staining is important. 1 plus means there's an incomplete staining. So entire membrane is not stained. But 2 plus means the entire membrane is stained, but it's weak to moderate intensity. And it's more than 10% tumor cells. So the patients who show this pattern of staining and they do not show any amplification, FISH is negative or any in situ techniques is negative, they are also categorized in the HER2 low. So next slide. There's a no change for the HER2 positive patient. That means who show the weak to moderate complete staining in more than 10% cells and HER2 amplified, they are considered the HER2 positive. And 2023 ESMO clinical practice recommendation is also the same. They are the HER2 positive. Similarly, those patients who show the intense complete staining in more than 10% tumor cell, they are considered the HER2 3 plus. And according to the ESMO consensus, 2023, they are also HER2 positive. So our basic difference in that is the positive patients, no problems is there, who are the clear-cut positive. That means who show the either complete staining in more than 10% tumor cell, strong staining, or weak to moderate staining and complete staining in more than 10% tumor cells with FISH positive. They are the no problems in the reporting. Only the changes have made between that in the low and ultra low. So low means the patient which shows the 1 plus staining or 2 plus staining with the FISH negative cases. And ultra low means who are more than 0 but less than 1 plus. They are considered the ultra low. So these two groups we have created according to the 2023 ESMO clinical practice recommendation. Next slide, please. So what is the benefit of this scoring system? So previously, HER2 positive, that means who shows the 3 plus staining by IHC or 2 plus staining with in situ hybridization positive. That group comprises only 15% of the breast cancer patients. So already 85% patients are considered the HER2 negative patients, and no targeted therapies is available for them. They're treated according to their ERPR status and others AS status. So HER2 targeted therapy, that means the Herceptin is basically only available for these 15% patients. So when we just categorize the patients in the low or ultra low group, then we have seen that 60% patients among these 85%, they're actually low or ultra low. And only 25% patient is actually the HER2 negative, that is the null type. So these 60% patients now can be benefited from this new medicine, the antibody drug conjugates. That is the beauty of this scoring system. So previously, all 85% patients, as you know, targeted molecules are there available. But now, the only 25% patients, they can be treated, no targeted molecules are available. These remaining 60%, who are considered the low, we are categorized as the low or ultra low group, we can give them, a medical oncologist can provide them the antibody drug conjugate. Next slide, please. So What is the ASCO-CAP guidelines update for 2023? Number one, till now we are using the HER2 as a predictive biomarkers and to identify the patients who can be benefited, who have the basically HER2 mediated pathway in the tumorigenesis. That means the patient who shows the IHC 3+ and 2+ with FISH positive, where the HER2 mediated pathways are there in their tumorigenesis. And they are basically benefited from the any drugs like the Herceptin, which disrupt the HER2 signaling pathway. Number two is that, okay, apart from this, the patients who have the scoring ultra low or the low, that means the patients who are the 1+, 2+ FISH negative, this group, and the patients who has the more than 0 but less than 1+, ultra low group, this cohort of the patients also can be benefited from the drugs which does not disrupt the HER2 signaling pathway, but which can use the HER2 molecules as a gateway to deliver the cytotoxic drug. So that's why the ASCO-CAP guidelines update 2023 recommend to make a footnote. That is, I have just made here in this slide in the invited comma, that patients with the breast cancer that are HER2, IHC 3+ or IHC 2+ and ISH amplified may be eligible for several therapies that disrupt the HER2 signaling pathway. Invasive breast cancer that are HER2 negative, that means IHC 0, 1+ or 2+ with ISH non-amplified, are more specifically considered HER2 negative for protein overexpression or gene amplification. Since non-overexpressed level of HER2 protein may be present in this group, in these cases, patients with breast cancers that are HER2 IHC 1+ or IHC 2+ ISH non-amplified may be eligible for a treatment that targets non-amplified, non-overexpressed level of HER2 expression or cytotoxic drug delivery. IHC 0 result do not result in the eligibility currently. Next slide. So this is the reason of the new scoring system. And by this scoring system, I have already described that which particular group of patients will be benefited. Now, IHC for the HER2 new or the FISH for the HER2 new is not a very easy method, very easy techniques. There are lots of problems can appear, and my pathology colleagues as well as the clinical colleagues should be aware of these problems. So we can group this problem in a pre-analytical, analytical, as well as the post-analytical. So pre-analytical problem means the biggest challenge is the time of slicing and fixation. Second is that what type of the fixation we are using and the duration of fixation. If we go for the under fixation or over fixation, it can directly hamper your HER2 new result, both in the IHC and the FISH techniques. Method of the tissue processing, assay validation and equipment calibration, all are these pre-analytical factors which directly influences the HER2 result. And finally, the treatment of the patients can be changed. Analytical, staff competency, type of antigen retrieval, and test reagent, what are you used? Is there a USFDA approved reagent are using the lab, or just any other reagents are used in the lab? And what are the post-analytical? So what are the control are using? What is the assay conditions? If we're using the digital pathology for HER2 reporting, then the image analysis software, is it using USFDA approved or not? And interpretation criteria and scoring system. So everything, these factors influence your patient's HER2 new report. Next slide. So I'm not going very detailed descriptions of these pre-analytical, analytical, post-analytical, because it is not a suitable place for the discussing all this in very details. So a very nutshell, I'm just describing that. So to get the optimized HER2 IHC result, what we should go for it. So cold ischemia. Cold ischemia means when the specimen is released from the is removed from the body, either biopsy or the excision specimen, and when it is placed for the fixation, this time duration is called the cold ischemia. So cold ischemia time should be very, very minimized, and better it is less than 1 hour. If it is more than 1 hour, then what happens? The lots of enzymes are activated, lysosomal enzymes, which proteolytic enzymes or nucleolytic enzymes, which disrupt the DNA and RNA molecules as well as the HER2 protein molecule on the cell surface, and the report can be changed. Second is that fixation time in the 10% neutral buffer formalin. So that is very important. 10% formalin is not enough for the optimum HER2 report. The neutral buffer formalin. Buffer formalin means it is the sodium dihydrogen phosphate buffer should be present in the formalin, and the pH should be the 6.8 to 7.4. I will show you in the details in the next slide. And the fixation time should be in between the 6 hours to 72 hours. So the labs which basically works in a hub and spoke method. That means there are lots of collection center in the periphery, and the central there is a lab. They are collecting the samples and they are sending to the central lab, either in the Delhi or in the Gurgaon or in the Bangalore. They are sending their samples in the formalins, and the traveling time is more than the 72 hours or anything. So then definitely your HER2 reports will be the hampered. So better it is to establish the local labs which is very much equipped with HER2 testing and this all, either the IHC or the FISH. And the section should be the 5 to 10 millimeter thick for the proper fixation. So when you get the breast specimen, the pathologist should make the slice the 5 to 10 millimeter thick, so that the proper fixative materials, 10% neutral buffer formalin, it introduced in the tissue and the fixations can be done. Next slide. So just I'm changing this. Next slide, please. Next slide. Next slide. So these are all details on the how to manage these situations. What is the best way to getting the samples and all. I'm not going into any details discussion on this. Next slide. Yeah. Next slide, please. This is the important. This we have to know. Tissue handling and the cold ischemia. So I already described what is the cold ischemia. So what is the warm ischemia? Warm ischemia means when they just clamp the supplying vessels in the body and they remove the specimens. That is called the warm ischemia. Warm ischemia also definitely influences your nucleic acid conditions and your receptor status. But you cannot control the warm ischemia. It depends on the surgeon's efficacy. It depends on the complexity of the operation and all. But the cold ischemia time which can minimize as soon as possible. And to minimize the cold ischemia, the proper training of the nurses who present in the operation theaters, the technologies is important. We have to maintain the proper records of the cold ischemia in each and every cases. Okay. So if we can reduce the cold ischemia in less than 1 hour, at least, then the proper fixation is adequate and the reports are adequate. Next slide, please. So I've already described, but in these slides in details, I'm just telling the 10% neutral buffer formalin, which is pH 6.8 to 7.4 is essential for the optimum HER2 report. And the date of preparation of formalin should be recorded. Why? Because the more than 5 days preparation, if it's there, then the formalin, the quality is decreased and the fixation not done properly. So fixation time should be recorded. The fixation time for the small biopsy should be at least 6 hours. And for the large specimen, it is 12 to 18 hours. Beyond 36 hours, if we go fixation, then definitely the false negative results are high. False negative results will be increases. So pH should be monitored daily, and you should keep the pH in 6.8 to 7.4 in our lab. Formalin fixation of the tissue specimen at 4 degrees centigrade show the better nucleic acid preservation, but it is difficult to keep all the formalin container in the 4 degrees centigrade temperature in the low resource country like India, and where the cancer burden is so high. Tissue sections I've already described should be the 4 to 5 millimeter thickness. And what is the volume of the formalin to the tissue, the volume ratio? It should be at least 4:1. So what is the size of your tissue? The 4 times formalin should be there. Ideally, it should be a 10:1. So mainly the labs, which I have already told, which works in a hub and spoke model. That means they are collecting the samples from the periphery and the sending. They are not using these 4:1 criteria and all. So that's why the tissue fixation is very poor, and finally the HER2 result, both in IHC and the FISH or DD's techniques is jeopardized. Next slide, please. So these are the tissue processing, some guidelines. I'm not going into very details. Okay. This next slide, please. So what is the analytical factors which influences the molecular profilings, ISP profilings is true for the everything. So we should avoid the slides where there is a large area of necrosis, large area of hemorrhage, or large mucin pools and fibrosis. So selection of slide is very important. Which block we should go for the HER2 testing? This is basically a discussion for both my pathology colleagues and my clinical friends or seniors present here. So we should choose the slides where there's a minimum necrosis, minimum hemorrhage, minimum fibrosis, touching artifacts are minimum. And if there is an area where the large area of necrosis and everything is there, then we go for the micro dissections. And the proper tumor area only, we should go for the FISH and other techniques. Okay. For the FISH-based biomarker assay, at least 50 viable cells should be there. And section thickness should be at least between the 2 to 3 microns. Okay, for the NGS test, similarly, the DNA and RNA requirement are 100 to 150 nanograms, and 4 to 6 sections of 10 micrometer thickness of the 15 or 15 to 20 unstained lines will be adequate for this amount of the good quality DNA. Next slide. So these are the post-analytical variables. So one of the most important factors for the HER2 testing, because lots of the patients who not done the HER2 testing initially, so their blocks are kept in the hospitals or in the labs, and subsequently after 2 or 3 years, when the tumor recurs, then the medical oncologists see that no HER2 test was done initially. They just ask for the previous HER2 status. The patient comes to the lab for the retrieval of the blocks. So the storage condition should be the dry, their paste-free condition, and the room temperature should be between the 18 to 25 degrees centigrade. Otherwise, the quality of the blocks will be the deranged. Paraffin blocks should be stored in a temperature-controlled environment, protected from the excessive humidity, dryness, and lights. But unfortunately, most of the hospitals, the storage area for the paraffin blocks and slides is extremely poor. They're mostly in the top of the roofs where the temperature is very high, and it is not dry, it is just shaggy, and paste controls, they are not properly maintained. So tissue establishment of the tissue repository for the fresh tissue that can be stored for several years for research purpose, that was also be helpful for the optimum HER2 reports in patients. Data preparation of the tissue blocks and slides, condition of the block storage, temperature, humidity of the storage area, that should be recorded. Block retrieval and block filing should have some defined protocols and SOPs that block become accessible whenever it is required. So these are all the post-analytical factors which influences your HER2, and not only the HER2, other biomarker evaluations, biomarker results also. So this is the next slide, please. Yeah, so this is a very interesting paper that is published by the Tata Memorial Hospital, Bombay, by our HOD madam and the molecular biology department, Sangita Desai madam and Tanuja Shet madams. And it's nicely, this paper is very helpful for our pathology friends, that it is nicely described what should be the analytical factor, pre-analytical factor and post-analytical factor, how it can influences the HER2 reports, HER2 results, other biomarker results, and how we can achieve the ideal and optimize the HER2 and other biomarker results. Okay. Next slide, please. So what are the issues that is associated with the HER2 low testing? Not for the HER2 the high testing, HER2 low testing particularly. So the samples, what we should test for the HER2 low and ultra low, the blocks are only the material. There is till now there is no any standardized protocol for the cytology specimens. Okay, so blocks, either cell blocks or the paraffin blocks, that should be tested for the HER2 low and ultra low. From the cytology, the smears, we can't test currently. No standardized protocols are there available. And what platform are we used for the IHC for the HER2 low and ultra low? So Destiny trials, they have used the Ventana 4B5 systems, and the lock protocol they have used. And it is advised we should use this platform for the IHC. And staining protocols, variation, if we go for any variation in the staining protocol, that can influence the result. So better to go for the protocols which used in the Destiny trial. There are the lots of pre-analytical variations I've already described, which can influence this. It is similarly, they are true for the hard-to-low testing also. And low positive controls should be used in the slides as a control material. Next slide, please. So apart from the breast cancer, we can use other solid cancer also, like your biliary tract and gallbladder cancer, colorectal cancer, uterine serous cancer mostly, less commonly in the endometrioid, hard to low lung cancer, which are basically mutation based, where the single nucleotide variants or the exon 20 insertions are a potent biomarker for the antibody drug conjugates and all, and obviously for the gastric cancer. One thing I am not going in details here, but the scoring systems is different for the gastric cancer and other cancer from the breast cancer. Breast cancer, we emphasize on the complete membranous stainings, where in the gastric and other cancer, the basolateral or lateral membranous stainings is the mostly considered. Next slide. So till now, the IHC and the in situ hybridization techniques are the preferred method for the assessment of the HER2 for the low, ultra low, and the high for every cases. And it is approved by the US FDA. And it is approved by the US FDA only. So it is the question that do you need any molecular test to define the HER2 low? Why I'm telling so that because IHC and your in situ hybridizations, if we don't using the digital platforms, they are mostly subjectives. Okay, but if we go for the molecular test, like your NGS based test or the ddPCR based test, then it is much more be objective. So the reproducibility can be the much more high. That's why I'm making the question marks here in the slides. So any molecular test we can use for to assess the HER2 low status. So mRNA levels of a tumor across the HER2 low cancers were overlapping. So I have seen that patients who have the IHC is 0 or maybe the 0 plus, that means the surface expression of the HER2 molecule is very low. That patient also have the mRNA levels which are equivalent to, if not higher than, to the patients which shows the IHC 1 plus or 2 plus. That means the group of patients by IHC where we are considering them as the HER2 null or HER2 ultra low, they also have some extent of the mRNA on their cytoplasm, which is equivalent to the patients which shows the HER2 1 plus or 2 plus in IHC. So to identify this group of patients, the droplet digital PCR is one of the method of choice. So, and in ddPCR, if we get the cutoff, basically this is a very nice study. It is done in my previous institution, the Tata Memorial Hospital, Bombay, where they have shown that the 490 mRNA HER2 copy present, 490 mRNA HER2 copy, then there is a 100% agreement. Then you can consider patients the HER2 positive or negative. Okay, it is not published. The data is not published till now. So this is the molecular techniques we can use. But the one big challenge similarly is that the HER2 is not very homogeneous biomarker. It is a very much heterogeneous. The area which shows the HER2 positive 3 plus in the same patient, same tumor slides, we can get the area which shows the 2 plus or even the null type of HER2 expressions. So this heterogeneity also influences the ddPCR method also, and the result can become the dubious. That is next slides. Thank you. And any queries from the audience will be highly appreciated.
It seems like there are no questions. Thank you, sir. Thank you so much for an insightful session.
Thank you, everyone.
Now we move on to the panel discussion. Topic of panel discussion is HER2 scoring in breast cancer, clarity in classification, confidence in care. I would like to welcome Dr. Debashish Bhattacharya, who is moderator for the panel discussion. And I would like to invite all the panel members, Dr. Anand Badia, Dr. Nirmal Banerjee, Dr. P.N. Mohapatra, Dr. Saurabh Bhaumik, Dr. Subbalakshmi Sengupta. Over to you, sir.
Good evening to all participants. I am Dr. Debashish Bhattacharjee, consultant oncopathologist at SCG Cancer Care, Kolkata. So, as we all know that HER2/neu is a key biomarker for guiding the treatment decisions in breast carcinomas. And so, on today, our panel discussion on HER2/neu scoring in breast cancer, clarity in classification, confidence in care will address to the challenges in the HER2/neu classification and confidence required in interpreting these results. I warmly welcome our expert panel members to contribute in this panel discussion. Next slide, please. Next slide, please. So as discussed by previous speakers, to summarize, actually the Destiny Breast 04 is a phase 3 randomized multicenter open label study to evaluate the role of trastuzumab deruxtecan, the antibody drug conjugate, versus the physician's choice of chemotherapy in the HER2/neu low metastatic or unresectable breast cancers. The trastuzumab deruxtecan demonstrated a statistically significant improvement in progression-free survival and the overall survival. The grade 3 adverse effects were less than the physician's choice of chemotherapy, and it showed a overall positive benefit and risk ratio. Next slide, please. The Destiny Breast 06 trial is another phase 3 randomized open label study which compared the trastuzumab deruxtecan with the physician's choice of chemotherapy in patients with hormone receptor positive HER2/neu low or HER2/neu ultra low metastatic breast cancer who had progressed on endocrine therapy. The results in the HER2/neu ultra low were consistent with the HER2/neu low cases, and the confirmed objective response rate was 57.3% in the trastuzumab deruxtecan versus 31.2% in the conventional chemotherapy. Compared to the Destiny 04 trial, no new safety signals were identified, and the interstitial lung disease remains an important negative safety risk factor. Next slide, please. So coming to our case discussion. So a 60 years old female presented in March 2021 with cough, dyspnea, and a palpable breast lump. She initially underwent a mammogram in which there was 8 into 4 centimeter lesion with diffuse suspicious calcifications noted in the upper outer quadrant of the breast. PET scan was done, and this patient had a diagnosed as a right breast carcinoma with right axillary lymphadenopathy. The CECT chest shows multiple bilateral lung nodules and presence of some mediastinal lymph nodes. Next slide. A bronchoscopy was done with a biopsy from the right lower lobe of the lung nodules, and a biopsy was also done from the breast mass. The H&E diagnosis from the bronchoscopic guided lung nodules was metastatic breast carcinoma, and the diagnosis of the breast mass from the breast two-cut biopsy was infiltrated ductal carcinoma, not otherwise specified. ISU was done initially on the breast mass, and it showed that ER was positive. 45% of the tumor cells displayed a strong, intense nuclear staining. PR was also positive with 55% of the tumor cells showing strong, intense nuclear staining. Ki-67 was 70%, and HER2/neu was reported as negative. On the treatment overview, the patient received first line of ribociclib with letrozole and zoledronic acid. Unfortunately, the patient progressed after 1.5 years with presence of bony metastasis. The patient was offered the second-line treatment with palbociclib and fulvestrant, but the patient presented with 2 months with progression in form of liver metastasis. Next slide, please. Now, my first question of this panel discussion will be to Dr. P.N. Mohapatra, sir. So, considering that the HER2/neu test was interpreted in a binary fashion, and it was reported initially by the lab as HER2/neu negative, would you consider this patient eligible for targeted therapy?
Actually, we'll try to rebiopsy actually here. Actually, we do rebiopsies actually, and we'll be very particular in somebody to report as either is a to low, ultra low, or 1 plus, 2 plus. We will not proceed without any rebiopsy here actually. But we will not stand the old slides actually here. We will try to do fresh biopsies.
Thank you, sir. The second question for you is that, sir, what are the clinical implications of HER2/neu low and HER2/neu ultra low in current practice and guidelines?
This is actually the typical patient for Destiny 06 trial. Actually, if somebody have a HER2 low, ultra low, actually. So this patient is actually progressing after first line ribociclib and letrozole, which is standard of care, and second line fulvestrant. I don't think palbociclib is any standard of care after ribociclib actually. But anyhow, is progressing with fulvestrant actually. So this is a patient actually after 2 lines of treatment. First line actually in metastatic 1.5 years, and second line 2 months actually. Here the main is actually you are out of hormone therapy, so you have to go for actually antibody drug conjugate if it is a hard to low or ultra low, or otherwise chemotherapy.
Thank you, sir. The next slide, please. The next slide, please. So the HER2/neu expression is actually dynamic. So if you compare the ISC results of a primary tumor with its metastatic counterpart, we can see that a primary tumor can be HER2/neu null, that is zeros on ISC staining, but it's metastatic when it's metastasis to the other side. If you do that HER2/neu staining, it can be either a HER2/neu null, that is HER2/neu 0, or it can be also HER2/neu ultra low, that means 0 plus staining. Similarly, a primary tumor with a HER2/neu low can be on metastatic, it can be HER2/neu low, or it can be HER2/neu ultra low. So that brings into the question that whether we should be doing ISC staining on both the primary and the metastatic origin. So I hope that that would be discussed in my upcoming panel discussion. Next slide, please. So this is actually the previous way of reporting HER2/neu. So it was expected that the HER2/neu testing will be done by in the invasive component only, not in the DCIS component, via validated ISC assay. So now, if you want to report HER2/neu as low and ultra low, you should be using the Ventana validated IC pathway, using the recommended 4B5 antibody and the UltraView platform, using either the Ventana GX or similarly platform. And in every run, you should run the appropriate batch controls along with the recommended positive and negative controls. And we have to make sure that the positive controls and the appropriate negative controls show appropriate staining before we uh, get to see the tumor sections. So previously, ISC 3 plus has not changed much. ISC 3 plus positive is defined as circumferential membrane staining pattern that is complete and intense in greater than 10% of the tumor cells. IC2 plus equivocal means weak to moderate intensity staining that is complete membranous in greater than 10% of the tumor cells, or it can sometimes show a complete intense 3 plus staining pattern that is less than or equal to 10% of the tumor cells. Recent ASCO-CAP guidelines has also included that some of the cases, especially in cases of micropapillary breast carcinoma, they can show moderate to intense but incomplete basolateral or lateral staining. Also, this staining also be considered as 2 plus. And coming to HER2/neu 1 plus, which is now considered as HER2/neu low. So incomplete, faint, barely perceptible membrane staining pattern in greater than 10% of the tumor cells. HER2 ultra low, that is 0 plus, that is membrane staining that is incomplete and faintly barely perceptible in less than equal to 10% of the tumor cells. And HER2/neu null, that is 0. There should be no or absent membrane staining pattern. Next slide, please. So my next question is to Dr. Shodo Bhomik. So HER2/neu expression in the breast tumor is dynamic. So for in this case, would you go with the historical HER2 score, or you consider doing a fresh biopsy to retest and rescore HER2, or you would to like to do a retest and rescore from the archival block? Your opinion,
Good
please.
good evening, all. See, in this case, actually, the previous HER2 scoring, which was done possibly in the according to the previous score which we used to follow, that was it was like as stated as negative, and that's why we have there is no point to give a Herceptin. So if we treat this case like want to treat this case, so we should do for a repeat biopsy, as I had already told, because and also should do the repeat HER2 staining from that fresh biopsy, because as you as we see in the previous slide also, the HER2 is a dynamic score, and if I presume that the previous biopsy might be negative or HER2 null, but there is a fair chance that it might be HER2 low or ultra low. So if it becomes HER2 low or ultra low, then we have a fair chance to give TDXT, so that the patient can be survived or better life expectancy you can expect from this case. So I will definitely recommend to go a fresh biopsy and not from the not go with the historical or previous HER2 score, and retesting from rescore from the archival block. Actually, the archival block, there is very a lot of problems, because how much the block is in good standard or not, we don't know. So in that case, also the protein expression, HER2 protein expression might vary, and also the condition of archival block, and that will reflect on the previous score. And as we are uh, discussing that HER2 is a dynamic one, and the previous score might change to the score where we can give drug. So I think it is the best way to go for a fresh biopsy and do fresh HER2 scoring on that.
Thank you, Dr. Bhomik, for your input. Next slide, please. So in tune with Dr. Mohapatro and Dr. Saurabh Bhomik, according to publications by the ASCO, it was noted that the patients with advanced breast carcinoma, which were previously diagnosed on ISC as ISC 0 status, on repeat HER2/neu testing, 43 to 45% of the patient were identified as HER2/neu ultra low, when these cases were rescored according to the new ASCO and CAP guidelines. Next slide, please. So in this case, a fresh biopsy was ordered to reassess the HER2/neu status in this case. Next slide. So my next question to Dr. Mohapatro sir is that we all know that HER2/neu intratumoral heterogeneity is a problem, and it has been reported in up to 40% of the breast carcinomas. So sir, what are the considerations for clinicians ordering a biopsy to account for the HER2/neu intratumoral heterogeneity?
We actually talk with the who is doing biopsy. Actually, we talk. Actually, we tell them to take multiple samples, and we try to take actually from metastatic site and primary breast also, if possible. And we to tell the pathologist to stand from both the sides, sides actually. Actually, we have seen a lot of times actually, na, the breast and the metastatic sites are different actually. That's why, unless it's very complicated biopsy, we try to do biopsy from both the primary breast mass also from the metastatic site, not from bone actually, but other metastatic sites.
Thank you, sir. My next question is to Dr. Anand Bardia. Uh, that how many in your practice, how many blocks you test for HER2/neu for a case actually?
So good evening, everyone. So usually when it's a breast biopsy, usually there are four cores, 4 or 5 cores, which are taken from various areas of the lump. So in that case, the blocks can be divided into 2 blocks, and then we do it on the 2 blocks. When we get a resection specimen, so what we do in that case is we take from various samples. The tumor is being sampled, and if we see that there is some change in morphology, on the morphology, there's some morphological characteristics that are different in different areas. So those areas can be done for retesting. And if it is in the
Okay, thank
biopsy, if
you.
the HER2 is negative and we get a resection specimen, then the HER2 is again repeated on the resection specimen to check out the actual HER2 status for any heterogeneity.
Okay, thank you. Sir, Dr. Mahapatra said, so what is the significance of knowing the HER2/neu status when you planned a adjuvant therapy for the breast cancer patients?
You have to actually, that is the, we always see targets actually. Now, you have to, if there is a target, hard to, then adjuvant treatment is very important actually. Actually, the if you see in a decade, actually, what has changed our treating breast cancer is actually trastuzumab, actually, hard to. So adjuvant, anybody nowadays, if you ask anybody, will tell ki HER2 is very important to give adjuvant treatment trastuzumab.
Thank you, sir. The next slide, please. So the next question is to Dr. Shubaloki. Ma'am, the Destiny Breast 04 and 06 trials have recommended using the Ventana 4B5 antibody to detect the HER2/neu low and ultra low cases. But we are aware of the problem that many labs in India also use other antibody clones. So according to you, will this impact the identification of eligible patients with the intent to treat with trastuzumab and deruxtecan? Can you please give your
Yeah,
comments?
good evening. So, the according to the Destiny breast trial 4 and 6, the eligible the cases who are eligible for the treatment is when they are using 4B5 antibody on specific Ventana platform. And we know that the labs in India are also not only using different antibody clones, but they are using sometimes manual staining as well. So this is not FDA approved, and definitely this will uh, affect the scoring of Fortinews specifically in case of those 1+ and 0+ staining.
Yes. Thank you, ma'am. The next slide, please. So, as said by all the panelists and the previous speakers, so it is imperative that we distinguish HER2 null from HER2/neu ultra low and HER2/neu low. But we are all aware of the problem that there is a interpathologist variation when we try to differentiate between 0+ and 1+. So it is recommended that we all know that when it's a HER2/neu 3+ scoring, it is easily recognizable at scanner magnification. That is, you look at the scanner magnification at 5x, and if it is 3+, the tumor cells are telling right on your eyes that we are 3+. When it is equivocal, that means the 2+ staining, we often go to a little higher power like 10x or 20x magnification to confirm our 2 plus staining. And for HER2/neu 1 plus and for 0 plus, it is imperative that we give a little more time in seeing the slides and going to higher power with 40x magnification so that we do not miss any focal areas of HER2/neu 1 plus or 0 plus, because that would change the HER2/neu classification to HER2/neu low and HER2/neu ultra low. And this patient can be used or can get the benefit of trastuzumab deruxtecan. The next slide, please. So this is actually the picture which is showing the difference in staining pattern between a IC3 plus, that is HER2/neu positive, followed by a IC2 plus. So if you get IC2 plus, it is imperative that you will order for a fish or in situ hybridization, and based on the results of the fish, it will be placed into either a HER2/neu positive or a HER2/neu low. If it is 2 plus on ISC and it is ISH negative, then it's HER2/neu low. If it is HER2/neu 1 plus, then again it makes sense to go to more magnifications at 40x to separate it from 0. And for HER2/neu ultra low, the same thing, that you have to confirm it with the 40x magnification so that you do not miss or you do not call it as a HER2/neu null, because then you are not giving the patient a fair chance of getting the treatment with trastuzumab deruxtecan. So the next slide, please. So what are the measures that we can all take to negate the subjectivity in HER2/neu ultra low identification? Apart from going to the 40x magnification, I would also suggest that whenever you are dealing with a problem like whether it's HER2/neu null or HER2/neu ultra low, you can always get a second histopathologist, oncopathologist opinion, so that if that is a if both of the pathologists agree that it's a HER2/neu low or HER2/neu ultra low, then it makes more confident diagnosing the cases as HER2/neu null or ultra low or 1 plus. And also we should be careful about our pre-analytics like cold ischemic time and the fixation time, because there can be non-specific staining pattern as well as cytoplasmic staining pattern. If this occurs, then it will be become life harder for the pathologist to distinguish between HER2/neu low and ultra low. And so going to higher magnification, consulting with your second uh, colleague whenever in doubt, and maintaining your pre-analytical, analytical, and post-analytical parameters will help you to to reduce the subjectivity in HER2/neu low identification. That is what my take. Next slide, please. So I would like to ask this question to Dr. Nirmal Lo. So according to you, sir, do the subtle differences in the staining pattern and intensity between the IC 0 and 1 plus pose a barrier in the identification of HER2/neu ultra low breast cancer cases? Basically, sir, I want to know that what is your take on reducing the subjectivity in this classification of HER2/neu 0, ultra low, and low?
Oh, so good evening, everyone. Thank you, Devasis. Finally, I got the opportunity to speak, indeed. So let me tell you, it is basically the inter-observer variability. And as far as the new classification is concerned, I think the training is most important. I think whosoever is practicing oncopathology, we should have an uniform, we should be in the same page regarding the HER2 reporting pattern. And obviously, as the previous speaker said, that manual staining is creating a lot of problem. Yes, I do agree with that. But having said that, in India, if you see the burden of the breast cancers, I think we have, in at least in our state, we have a great amount of heterogeneity as far as the IHC staining platform is concerned. So I think more and more amount of financial assistance is needed, and the inter-observer variability should be as low as possible, need to be done, need to be fixed up. So I spend time with the 40x. I think it is the dictum that if it is 0 or 0 plus, you should see more time in 40x. If it is 2 plus, you should spend more time on 20x. If it is 3 plus, you can see it on 4x or 10x. It's written there. So I think that's how we should do it.
Okay, so can doctor please elaborate what is your practice of reporting HER2 status in the breast cancer? What are you following guidelines in your workplace regarding the
You
reporting
see,
structure?
when I have started practicing this 1 plus, 0 plus, the moment I have started writing this, the clinical counterpart, they are also equally updated. They started asking, please mention the percentage of cells which are showing positive, because writing 0 plus is not enough, good enough to convince them. They want the percentage of cells which are showing positivity. So then I have started writing also that, sir, because of this and this, it is this. And of course, the 4B5 clone, I think that's the most widely used. And recently, I have installed the Ventana, which is the moderate size in my hospital also, just to avoid all those things related to that interpretation and all. So presently, I am following that only.
Thank you, doctor. And what will be your guidance to the my fellow pathology colleagues and different labs regarding the best practice they should follow to identify the HER2 ultra low and low breast carcinoma with confidence, and so that the results across the different labs are in uniformity is maintained? What
You
is your
see,
guidance
yeah,
regarding that?
yeah. So let me tell you, Devashish, a month ago, Dr. Tanuja Shet came into the R&T, and many people asked that, Madam, please update us about how to be on a same page as far as the HER2 reporting is concerned. So she said, and I also followed her after she said that the Roche website, they regularly update, the HER2 images in different sets. And I think the AstraZeneca also has taken an e-platform where they have performed two sets of tests, one via AI and one via manual. I think we all know this. So I think there are two things. One thing is that we must visit the Roche website, and especially their image banks, and to see. And then of course the AstraZeneca has taken a greater initiative across the country to teach us and to update us. So I think being updated is the most easiest thing we can do. And I think we all should be aware about the recent guideline which are there. So that's how we should follow the practice.
Thank you. Thank you. So the next slide, please. So my next question is to both Dr. P.N. Mohapatra sir and Dr. Anand Bardia. So we all know that the HER2 classification is evolving, and but the recent even the recent ASCO and CAP guidelines have mentioned that it is only optional till now to report the HER2 low and ultra low cases on the pathology report. So after a report is being generated from the histopathology lab, how do you think the multidisciplinary team discussions have become much more relevant and important in this context, because the classification keeps on changing and the treatment also evolves? So I would like to invite Dr. Mohapatra sir to comment first on this.
I think all the if you go all the central institute actually they include radiologist and pathologist in their any all tumor discussions actually. The main is pathology actually. We can always discuss with your pathologist. So ultimately, what we follow is what the pathologist give us report actually. Only thing if it is clinically not fitting or we want something better, then we can take actually discuss with the pathologist, or if we are not very satisfied, we can take a second opinion actually. Sometimes we have seen this is actually very important. And we have done wonder for the patients actually, especially somebody with breast cancer having a brain metastasis, and you don't have anything. If you get a 1+ HR positive also, then you have a lot of life given to that patient actually.
Thank you. And Dr. Bardia, any comments on this MDT discussions taking a very important role in this context?
Yeah, I completely agree with sir. Now, for cancer treatment, it's not the game of one person treating the patient. It's the whole team which actually treats the patient. And in that respect, the MDT plays a very important role where we can discuss with the pathologists, the clinicians, the radiologists, they can discuss if there's any discrepancy in the reports. That is why it's now a clinical pathological report. So if there is any discrepancy, it is being discussed in the MDT. Again, the pathologist can have a relook at the biopsy to address those discrepancies, or maybe we can go for a rebiopsy or second opinion. So MDT does definitely plays a very crucial role in deciding the management of the patient.
Thank you. Actually, the MDT discussions are a thing in the hospital, but the real problem that we all face, especially our colleagues who are working in the standalone diagnostics, is that they sometimes don't get the opportunity to discuss this recent changes with their clinical counterpart who is sitting miles apart. Actually, that is the problem that the standalone diagnostics face. But yes, the hospital in this context, the oncopathology centers have uh, the MDT discussions are quite common, and it is the end point of the MDT discussion that goes into patient treatment. Thank you. The next slide, please. So in these cases, the patient on rebiopsy was found to be HER2 ultra low, that is IHC 0 plus with membrane staining pattern, and it was reported according to the March 2025 updated CAP template. The next slide, please. So this is the updated CAP 2025 update, which is freely available in the CAP website, in which you have to fill in all the pre-analytical factors, whether the patient was what was the cold ischemic time, what was the fixation time, and what was the fixative that was used. And they have also in their description they have given the guidelines, which was also discussed by my previous speakers, and you have to give in the pattern of staining that is and the IC score 0 0 plus 1 plus 2 plus and 3 plus, and the interpretation that what are the number of cells that are showing the 3 plus staining pattern, whether there is any heterogeneity in the staining pattern or not. And it's now ASCO CAP guidelines tells you that it's recommended that you include a CAP protocol note in your report that says that about the HER2 ultra low and low cases which can be targeted by the trastuzumab and deruxtecan antibody drug conjugate. Um, and based on this report, the patient was finally administered with trastuzumab deruxtecan drug conjugate. And the next slide, please. So this is actually the tick mark we expect that all our pathology colleagues maintain when signing out a report on HER2 staining. We mentioned the score actually, the percentage of cells stained, and the intensity of staining as faint, barely perceptible, weak, moderate, and strong. The pattern of membrane staining, whether it is complete, incomplete, even basolateral, lateral. Uh, we include the ASCO 2023 footnote available on the ASCO website, the CAP template footnote available on the CAP guidelines on their website. If you are going by the 2 plus scoring, you can include the HER2 fish status in your report. If you are giving it to the reference lab, you can mention the same. And you have to mention all the analytical elements, that what are the primary antibody that you are using, what is the platform that you are using, whether what is the status of your positive control, your reagent negative control, and your batch controls, and any other pre-analytical factors like cold ischemic time, fixation time, the fixative use. So if you mention all this, it gives a confidence in reporting of the patient. It maintains the uniformity of the reporting, and it gives our clinical colleagues confidence in treating the patients. So I hope that this is all for me actually, and I'm very thankful for my fellow panelists to give us an insight on this much needed topic. That's all for me. Thank you. Thank you, my fellow panelists.
Thank you.
Thank you all. Thank you, sir. And thank you all the panelists. Now I request Dr. Devmalia Banerjee, sir, to give the session summary. Sir,
Thank
over
you.
to you, please.
Thank you. I'm very much thankful to the organizer, to Dr. Mahapatra sir, and to all our panelists here present for this excellent knowledge sharing platform, for the discussions. Lots of things we just can realize. Okay, what is the role of definitely for this new scoring system? The role of pathologists have increased, and we have to keep in mind the all pre-analytical factors, analytical factors, post-analytical factors, and we have to spend more time in the 40x microscope. So there's no problem with the 3 plus or the 2 plus FISH positive cases, but we should be very much cautious for the exact interpretation of the 0 plus and 1 plus cases, especially the ultra low and low cases, so that no patient should be missed, because this large number of these particular cohort that can be benefited by the antibody drug conjugates which is available nowadays. And we should be use the ASCO cap recent recommendations in the reporting format. The footnote should be there. And thank you very much for your kind attentions and these discussions, which is very much benefited to all of us. Thank you.
Thank you, sir. Now, coming to our last session of our day, we invite Dr. Ghanshyam Biswas, sir, for giving a talk on reshaping HER2 positive MBC with Tucatinib. Sir, over to you, please.
Please allow me for the slide sharing.
Yes, sir, please.
You can see my slides?
Yes, sir.
Okay.
Yes, sir. Now it's on full screen.
So thank you, IAIO, and thank you, NATCO, for this session. So in next 15 minutes or so, reshaping HER2 positive MBC with Tucatinib. So these are the three gentlemen who have contributed a lot to today's discussion. So we have been hearing for last 2 hours. So we talked about HER2 gene, which was discovered in humans in 1985. So credit goes to Dr. Axel Ulrich. And lots of efforts from Dr. Dennis Slamans, who has been the implications for HER2 overexpression, HER2 testing, and anti-HER2 therapy. And from Genentech, Dr. Shepherd has been in the anti-HER2 development. So these three pioneers have been working in the field of HER2 news since 1980s. And some of you may know, so Barbara Bradfield is the first lady who entered into the clinical trial of Herceptin, that is trastuzumab, in 1992. So, and if you go through the maladies of cancer, maladies of by Siddharth Mukherjee, so he wrote Barbara Bradfield was among the first women to be treated with the drug Herceptin that specifically attacks breast cancer cells. So she is the longest survivor of that treatment with no hint of cancer remaining. And people like her for believing in the work of our researchers. So we know the pattern of failure in breast cancer. So HR positive breast cancer, which is a predilection for a bone mets, but though we can see a visceral metastasis. Today's discussion is on HER2 positive, and like HER2 positive, even in TNBC, so there is a predilection for visceral metastasis, especially lungs, liver, and brain. So this cartoon shows, so on the left hand side, normal breast cells. On the other side is HER2 positive breast cancer cells. So in a normal cell, HER2 is lowly expressed or not expressed in breast epithelial cells. But in HER2 positive cells, so HER2 is amplified or overexpressions in this phenotype. You can see the number of HER2 amplifications in the nucleus and also in the cytoplasm. It has been well depicted here. So now coming to HER2 signaling pathways exacerbates breast cancer. So these ligands of the HER family promote HER2 homologous dimerization and heterologous dimerization with one another. So we have HER1, 2, 3, 4, and once there is a dimerization with HER1, 2, 1, 3, and 4 to activate downstream pathways. So that can be RAS, that can be RAF, PI3K, MEK, AKT pathways, and MAP and mTOR pathways. So which mediate the transcription of gene related to cell proliferation, survival, differentiation, invasion, metabolism, and angiogenesis. So HER2 positive breast cancer has an inherent risk of more relapses as compared to HR positive. If you see the cartoon before anti-HER2 was launched, so you can see there are larger peaks in the green and the blue, which are HER2 positive with either ER positive or ER negative. So hazards of relapse in early years are huge. So this was predominantly in the era when trastuzumab or no anti-HER2 was there. On the right hand side, you can see early 2004 and 2008 when we already had trastuzumab. So you can see the peak of the HR of relapse has come down in initial. So that was the impact of adding anti-HER2 with the systemic therapy in breast cancers. So now we have a plethora of choices for HER2 targeted therapy in breast cancer. So it can be HER2 targeted monoclonal antibodies. It can be HER2 targeted tyrosine kinase inhibitors. It can be HER2 targeted ADCs, and there are also bispecific antibodies. So it can be find out in one of those cell structures. So as I said, so the four group of drugs: monoclonal antibodies, TKI, ADCs, and the bispecific antibodies. The monoclonal antibodies that are already in place and also approved, one is a trastuzumab, then pertuzumab. India is lucky to have the biosimilar pertuzumab also. And the third drug we haven't have at this moment is the margetuximab. The action of the mode of monoclonal antibodies drug blocks HER2 signaling and we can see the diaminations and triggers HER2 endocytosis. So these endocytosed HER2 is degraded from the endozyme to the lysosome, and these Fc fragments of the monoclonal antibody recruits extracellular immune cells to perform the ADCC effect. And you can see, so these are the monoclonal antibodies: trastuzumab, pertuzumab, and margetuximab. So margetuximab probably have an additional effect of ADCC, which can be seen in this cartoon. The TKI that are already in breast cancer uses are lapatinib, neratinib, tucatinib, pyrotinib, afatinib, and dacomitinib. So most of us knows this afatinib and dacomitinib has been as an anti-EGFR rather in non-small cell, especially adenocarcinoma with exon 19 or 21. So in breast cancer, we have lapatinib, neratinib, and recently launched tucatinib. So we'll focus on that tucatinib part today. The action mode of TKI drugs blocks HER2 signaling, and you can see the binding site of the intracellular tyrosine kinase domain of HER124. And if you see on the right hand side cartoon, so as compared to tucatinib, lapatinib, which is there for quite some time now, and neratinib, so lapatinib also binds to HER1 and HER2, whereas neratinib binds to HER1 and HER2 and HER4, whereas tucatinib is specific to HER2. So tucatinib has high specificity to HER2 receptors compared to lapatinib and neratinib, which also binds to other HER receptors. Now coming to ADCs, so we have been hearing about the ADCs. So trastuzumab, ematenцine, again, so we are lucky to have the generics also. So it is also approved for breast cancer, but as compared to trastuzumab deruxtecan, which Dr. Mahapatra was speaking to, so it doesn't have a bystander effect. So as of now, we have two ADCs in place, that is trastuzumab, that is emtansine, that is TDM1, and trastuzumab deruxtecan. So there are a hell lot of other drugs in the clinical trials. There are another group of drugs in this space. So most of them are in clinical trial, either phase 1, phase 2, or phase 3. Some of the names are amivantamab and janitimab. So these are yet to be in the commercial use today. So the new kid on the block is tucatinib. So as I said, it is a tyrosine kinase inhibitor selective for HER2 as compared to lapatinib and neratinib. The small molecule tucatinib diffuses into the cell, selectively binds to the kinase domain of HER2 and inhibits activation of downstream signaling cascades. So dual inhibition of HER2, tucatinib has been combined with other agents that targeted the external domain of the HER2 in clinical trials. So tucatinib is highly selective for HER2 and is almost more than 1,000-fold more specific for HER2 than EGFR. So this comes as a 150 milligram a tablet. So the normal dosage is 300 milligram twice daily, continuous with or without food. It is usually given with capecitabine in the standard doses, 2 weeks on and 1 week off, and along with the intravenous trastuzumab, again at the doses we have been using for so many years now. Treatment should be continued until disease progression or unacceptable toxicities. So how do you titrate the dose of tucatinib in regards to non-hematological toxicities usually, which we'll see in a subsequent slide, is mainly a diarrhea, nausea and vomiting. So normally we start with 300 milligram twice daily, means 4 tablets per day. The first dose reduction, so you have to come down with 50 milligram each dose. So the next dose will be 500, that is 250 milligram twice daily. The second dose reduction will be 200 BD, and the third will be 150. So there is no dose allowed below the 300 milligram. So permanent discontinued tucatinib in patients unable to tolerate 150 milligram orally twice orally. To coming to special population elderly, so no dose adjustment is required for more than 65 years. Renal impairment, so more than 80 have not been included in the trial. Renal impairment, no dose adjustment is required with mild, moderate, or even severe renal impairment in regards to tucatinib. Hepatic impairment, so no dose adjustment required for mild and moderate. But yes, for severe hepatic impairment, that is Child-Pugh C, so you may start with the 2-dose reduction, that is 200 milligram twice daily. Pediatric population has not been established. So since tucatinib has to be used with capecitabine and trastuzumab, so in patients with severe renal failure, you may be able to give tucatinib and trastuzumab, but so you cannot give capecitabine. So that's how. So you cannot use this combination. So in severe renal failure with a creatinine clearance of less than 30, so capecitabine is contraindicated. Hence, so a combination of capecitabine, tucatinib, and trastuzumab in a severe renal impairment with a creatinine clearance of 30 will probably is not feasible. So we have to watch certain drugs. So while using tucatinib, so can be a strong CYP3 inducers. There can be a moderate CYP2C inducers, strong or moderate CYP2C inhibitor. So you need to put this in your room on the table, so that because it is very difficult to remember all the drugs and the interactions, so it is better to put. And then so once you prescribe, just see if the patient is on any of these drugs, so that which can be an inducers or an inhibitors. So in now HER2 positive MBC, so what are the options today beyond Cleopatra? So you know that Cleopatra, the median OS has almost been there for now 5 years with trastuzumab, pertuzumab, and taxane, with a median follow-up of almost 100 months, and we already have an 8-year data. Somebody who is not a candidate for docetaxel, so you can always replace with a paclitaxel or nab-paclitaxel. So last year there was a trial for those patients where you want to avoid taxanes for one or the other reason. So it can be replaced with eribulin as a non-inferior, like instead of THP, it can be eribulin with HP. Achieving radiological CR at 9 weeks associated with improved OS, not PR or a stable disease, overall response rate of 80% and 13% CR. So there is something called like a HER2-DX mRNA score, which we don't have yet. Strong association with PFS and OS, higher scores, better outcome. Now everybody is talking about the Destiny Breast 09, which probably will see the daylight in the frontline TDXD in a metastatic setting. So role of systemic therapy in setting up HER2 positive MBC with controlled CNS metastasis and no extracranial. It can be a trastuzumab deruxtecan, it can be tucatinib, capecitabine, and trastuzumab. TDM1, especially for those where the adjuvant trastuzumab has been less than 6 months, and chemotherapy plus trastuzumab, pertuzumab if it is more than 6 months, and neratinib, capecitabine, or lapatinib, capecitabine for modest response toxicities. And very rarely, with the high risk consent, you can consider for a intrathecal trastuzumab pertuzumab for carcinomatous meningitis. So coming to the tucatinib pivotal trials, so there are 2 phase 2 trials and 1 phase 3. So HER2 climb is a phase 2 study in the total population, and HER2 climb the same study which looked into a brain metastasis. So either active or a stable brain metastasis. And the third, which was a phase 3 trial of HER2 climb 02. So HER2 climb, which published in 2019, which was presented in San Antonio. So this phase 2 study used tucatinib with trastuzumab and capecitabine for a previously treated HER2 positive metastatic breast cancers. So around 600 patients who were exposed to trastuzumab, pertuzumab, and TDM1. The experimental arm was tucatinib, trastuzumab, capecitabine, and the standard arm was trastuzumab, capecitabine with a placebo. The primary endpoint was a PFS by BICR, and this was among first 480 patients. And rest was secondary endpoints in the total population, which included overall survival, PFS in patients with brain metastasis, overall response rate and measurable disease, and also the safety. So you can see the baseline characteristics were well balanced, and see almost 48% patients in the study in both the arms had a brain metastasis. So either treated or untreated or treated and progressing. 60% patients were hormone positive and 40% patients were HR negative. So coming to the primary endpoint, that is PFS, you can see the curves wide separating, and there was a 46% reduction in risk of disease progression, which was favoring the tucatinib arm. So tucatinib arm had a median PFS of 7.8 versus the placebo arm with trastuzumab and capecitabine around 5.6. And at 1 year PFS, 33 versus 12. Coming to OS in the total population, again 34% reduction in risk of death. So at 2 years, when 45% of patients were in the experimental arm, whereas half the patients were in the placebo arm. So with a median OS of 22 months versus 17 months. If you see the PFS and OS subgroup analysis, so all this, so be it age, be it the hormone status, and the presence or absence of a brain metastasis, so the tucatinib arm favored in both PFS and the OS. So PFS in patients with brain metastasis, you can see again 52% reduction in the risk of disease progression, which shows that this drug is very active with the brain mets, and which is usually the natural history of a HER2 positive disease. So 7.6 median PFS in brain metastasis as compared to 5.4. And the good part is that 1 year PFS in the tucatinib arm was 25%, where you can see a 0 patients who was surviving in the in the standard arm. If you see the subgroup analysis in the brain metastasis, again tucatinib arm favored, so be it a younger age, an elderly age, different race, or even the hormone status. Looking at the responses by the BICR, you can see a significant difference p-value. So 41 versus 23%. So almost more than half of the patients had a response with the tucatinib, trastuzumab, capecitabine. If you see the tucatinib, there were more of a partial response. If you see the placebo-controlled arm, so which had more of a a stable disease. Again, as expected, progressive disease were more in the control arm. So what are the common toxicities? So diarrhea has been there as the common toxicity in the tucatinib arm, and the hand-foot syndrome is usually contributed by the capecitabine. And rest, nausea, fatigue, vomiting, stomatitis, appetite decrease, headache, and alteration in the SGOT, SGPT in the liver enzymes. So diarrhea became the most common adverse event in both arms because so it can be contributed by capecitabine. It can also be contributed by the tucatinib. And antidiarrheal was used on almost 50% of the patients. Hand-foot syndrome was common in both the arms because both the arms had capecitabine. But in fact, the tucatinib arm had more of hand-foot syndrome because more patients were on the combination because of the duration of response. So that was the reason that the patients were more of with capecitabine and tucatinib in as compared to the patients who are only on trastuzumab and capecitabine. So the conclusion of this HER2 CLIMB phase 2 study. So this showed that improved outcome and response rate as compared to trastuzumab capecitabine. So reduced risk of death by almost 1/3 in the total population. Reduced risk of disease progression or death by almost 50%. Nearly doubled ORR, so 23 versus 41%. PFS and OS benefit from tucatinib consistent across all the subgroups. So tucatinib, trastuzumab, capecitabine was well tolerated except a significant amount of diarrhea is there and with mostly low-grade adverse events. So investigator concluded that tucatinib, trastuzumab, capecitabine has the potential to become the standard of care in heavily pretreated with trastuzumab, pertuzumab, and even in the TDM1. The second one was the similar trial, same trial, where we looked into the brain metastasis, and this was in the ASCO. The initial was in San Antonio, the subsequent year in 2020. So 291 brain mets, so 174 with active brain mets and 117 stable brain mets. So in all patients with brain metastasis, CNS, PFS, and OS, in patients with measurable intracranial disease, intracranial overall response rate, and the intracranial duration of response. So these are well balanced, both the arms, the trastuzumab, tucatinib, and capecitabine versus the trastuzumab, capecitabine in the placebo. Now, if you look at the primary endpoint, the CNS PFS in all patients, so huge 68% reduction in risk of CNS progression or death. So you can see a 1 year CNS PFS was 40% versus hardly any patients in the placebo arm. Median CNS PFS 9.9 versus half, almost 4.2 in the placebo arm. Coming to OS in all patients with brain metastasis, you can see a 42% reduction in risk of death. So 70% at 1 year OS with the tucatinib versus 46% in the placebo, and median OS was 18 versus 12 months. So now the CNS PFS and OS in patients with active brain mets not requiring local therapy. So the delta of benefit is 5.4 months, and OS delta benefit is almost 8.7 months. So 64% reduction in risk of CNS progression or death and 51% reduction in the risk of death. So coming to a stable brain mets, so almost a delta of 8.3 months in terms of CNS PFS, in OS almost 2.1 months. So 69% reduction in risk of CNS progression or death, 12% reduction in the death. If you see again a response rate of 47%, the CNS one with the tucatinib arm versus 20 in the placebo arm. Objective responses of confirmed CRRP are 26 versus 4, and duration of intracranial response was almost 6.8, which was almost double of 3 months in the placebo arm. So the conclusion of HER2 CLIMB intracranial activity, so the combination improves intracranial overall response rate, CNS, PFS, and OS, 68% reduction in the risk of CNS progression, 40% reduction in risk of death. CNS, PFS, and OS benefit observed in patients with brain mets. Current study is the first randomized control study to report a TKI leading to a prolonged OS in patients with HER2 MBC and brain mets. So taken together, HER2 CLIMB primary analysis investigator conclude that regimen is active against intracranial and extracranial disease in HER2 positive MBC. The third and the last pivotal trial is HER2 CLIMB 02. This is the only phase 3 trial. So where TDM1, that is trastuzumab emtansine, was combined with tucatinib in previously treated HER2 positive MBC. So around 460 odd patients. So these patients were exposed to trastuzumab and taxanes. So in their usual doses, primary endpoint of PFS and the secondary endpoint was hierarchical OS, PFS and OS in patients with brain mets. So again, well balanced both the baseline characteristics. And if you see the median PFS, which was 9.5 months in the TDM1 plus tucatinib as compared to only TDM was 7.4 with the hazards of 0.76. Coming to PFS in patients with brain mets, which was a secondary endpoint, median PFS of 7.8 versus 5.7 with a hazard of 0.64. That is means 36% reduction in death. Secondary endpoints are overall response rate and OS. So 42 versus 36, and partial response, again, partial response were a bit more in the TDM1 and tucatinib arm as compared to the TDM1 alone. So median OS was not reached in the experimental arm versus 38 months in the TDM1 and placebo arm. So the conclusion of HER2 CLIMB 03, that is a phase 3 study, that combination significantly improved median PFS and median PFS 9.5 versus 7.1. The PFS benefit was consistent across pre-specified subgroups. OS data is immature. Safety profile, now by this time we know that, so diarrhea is the only limit factor. Investigator concluded that this was the second randomized study demonstrating tucatinib-based therapy delays disease progression in HER2 positive MBC. So this drug has now been approved by European medical agencies, the US FDA, the Health Canada, and also the Australia. And now India has also received the first generic of this tucatinib, which was long awaited for. So either it is an active brain mets or a brain mets which is stable. If there are active brain mets, then probably the first choice will be a tucatinib-based, tucatinib, trastuzumab, and capecitabine. Brain mets possible to defer local therapy, CNS response is desired. Again, so it can be the combination of tucatinib, trastuzumab, capecitabine. Systemic progression and CNS disease, so probably the choice will be better with the ADC, that is TDXD, and the second choice will always be a tucatinib, trastuzumab, capecitabine. Now, since the generics are available, all the three, so probably the cost will be an important role. Brain mets for who are not affording, for those patients, you can still offer them lapatinib and capecitabine, because you know that lapatinib is a small molecule and that has a beautiful brain penetration. No or unknown or stable brain mets, then you have choices of TDXD and TDM1. So these are NCCN guidelines. So you know the first line, second line, third line. So these are rapidly changing with the induction of so many drugs. Now trastuzumab deruxtecan is seen in all the places now. So these are ESMO guidelines. So on the first line, if it is HR positive, HR negative, chemotherapy contraindications or not. So if somebody is not keen for chemotherapy or not a candidate for chemotherapy, then you can always get away with trastuzumab and pertuzumab with endocrine therapy. And now after the PATINA trial, now you can also use the CDK4/6, that is palbociclib, with trastuzumab and an hormonal treatment. So this is a beautiful cartoon from San Antonio. So somebody who is exposed to taxane, trastuzumab, pertuzumab. So now if there is active CNS disease, then probably tucatinib, trastuzumab, followed by TDX1, and somebody who cannot afford TDX1, then TDM1. Somebody who has a stable brain metastasis, then probably TDXD will be the first choice. The other drugs we are yet to have is the margetuximab and neratinib. We are still getting the drugs from an Indian house. But that is the original one. And as I said, so PATINA is already there because the PFS of 44 months in a patient of triple positive, that is ER/PR positive and HER2 positive. So optimizing therapeutic sequences is a crucial in the era of expanding HER2 targeted options, and we Indians are lucky as a physicians that we have so many generics of anti-HER2 agents in our kitty, which many country don't have. So this is the last slide. So thanks to NATCO, so they have their the biosimilar molecule Tucanat, and I thank my colleagues Dr. Bhabhi and Dr. Ranjan thus for helping me with the slides. So thank you so much. So that was the last slide. Over to the organizers.
Thank you, sir. Thank you so much for the informative session. There are no questions from the audience also, sir. Thank you so much for spending your time with us in the late evening. I thank all the panelists, faculty for joining us today. I thank all the attendees also taking time with us and having this session. Thank you. Good night, all.